magic button and go live. I've got no idea how it works, which is why I describe it as a magic button. Excellent morning, everybody, and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name's Kevin Lockyer, and welcome to our meeting this morning. Our approach usually at Board of Directors meetings is to start our meeting with a patient or staff story. We do that because we think it's a really good way of framing our discussions, which sometimes might otherwise be perceived as a bit ethereal at times, but it helps us kind of stay grounded, I think, with the realities of delivering services to the public of Lincolnshire. So it's an absolute privilege this morning that we are joined by a former service user, Martha, and a number of staff, including Jessica and some colleagues. I won't name you all, forgive me, but you're all welcome this morning, and we're really keen to hear what you have to say. So I will hand over. Jess, am I handing over to you to kick things off?
Yeah, good morning. I'm Jessica Howland, Service Manager for Personality and Complex Trauma team, and I'm joined by Martha, who has been a part of our service and is very kindly willing to share a summary of her journey through services, and Elle Cheel, our team coordinator, and Amanda Tetley, our consultant psychologist and clinical lead, are also on the meeting and have worked directly with Martha. So thank you very much for inviting us to join you, and thank you mostly to Martha for being so willing and enthusiastic about coming and sharing her story this morning. So I won't take up any more of Martha's time and let her present her story.
Hi everyone, so I'd like to thank you all for having me, and I appreciate you wanting to hear about my story too. So I've had quite a lengthy journey with mental health services. So I started my journey with CAMHS and had quite a lot of their input. I struggled quite a lot to express sort of the issues that were going on for me at the time, and I tried to do this in ways that I knew how. But at times I did feel quite dismissed and wasn't taken seriously, felt that I wasn't listened to, and was often asked to engage in treatments that I didn't want to do, I didn't feel were right for me. I tried to seek out help coming towards the end of my CAMHS journey myself, and it worked quite well for a short period of time. And I did this by trying to just move on from my experiences and kind of just brush them under the carpet, I guess. And I managed to gain some work, which was with the trust at the time as a clinical apprentice. And I just tried to put all of my energy and focus into that. I worked for the trust just short of a year, and I loved every minute that I did it. But unfortunately, you know, my issues returned to the point, you know, where I was too unwell to work, and it was deemed that I needed, you know, hospital treatment, which unfortunately was on section. My first experience of sort of hospital treatment was unfortunately out of area, which was mainly obviously due to me working for the trust, but this was quite far out of area, which was close to Brighton. And obviously, you know, with my family living in Lincoln, my family being unwell, and they were unable to travel to see me, so I didn't receive any sort of family support during this time. The only sort of support that I did get from my family was through occasional phone calls, but due to, you know, the remote location of the hospital, there was no sort of consistent phone signal for me to be able to contact my family and vice versa. And I was also unable to use a hospital phone, so it made things really difficult to try and keep in touch with my family. More inpatient stays, you know, came following from this, and in total there were 10 different hospitals. You know, again, due to my fluctuating needs, all of these again were nowhere close to where my family could see me at the time. And also, I just want to highlight that each time I was moved from one hospital to another, my mum, who is obviously my next of kin, she was never informed that, you know, I was going to be moved. There was no sort of contact details for these hospitals given to my mum, so she could make sure that I was okay, which obviously, you know, caused a lot of worry and stress for my mum, which she didn't need. So more hospital stays and sections. So that the longest time I was sort of in hospital was like without sort of any time in the community was around 2 years. You know, it's a long time to be in hospital away from family and not having that support. The longest sort of hospital that I stayed, it was a rehabilitation unit, which specialised in personality disorders, and I was told, you know, by hospital staff and other people that I'd received the help and support and, you know, specialist therapy that I needed. I spent a total of just over a year at this hospital, and I think from that hospital stay I gained more trauma than what I went in with. You know, it was absolutely horrendous. It was just not good at all. You know, through all of these hospital admissions, many times I would try and advocate for myself, you know, challenge decisions that were being made, you know, about my care without my input or involving me in any way at all. It was just put down to challenge and behaviour. You know, what wasn't the case at all. It was me trying to say, is this necessary? Do I need this? Do I need that? Would this be better? As well, you know, through these hospital stays, I just want to highlight that as someone who has several chronic conditions like physical health conditions, physical health needs to be taken more seriously through mental health services, you know, especially the inpatient areas of, you know, hospital stay where people are in other people's care for a long period. So while I was in a rehabilitation unit receiving treatment, I was quite unwell physically, and I, you know, tried to flag this with staff that I wasn't feeling well, but I was just ignored, dismissed, told it was all in my head, and it turns out that I actually had an infection that got so badly out of control and just left untreated for so long, it developed into sepsis, and I was actually quite extremely poorly. And also, again, you know, during this time, my mum, who was obviously in Lincoln and I was out of area, she just wasn't aware that I was so poorly and, you know, receiving treatment for a physical condition in hospital. Nobody contacted her, and it was me that, while I was receiving treatment and feeling a bit better in hospital, that I'd contacted her. She, you know, she was extremely worried and, you know, concerned that she hadn't heard from me, because obviously our only method of contact was phone call and text. But before all that happened, you know, I was told by staff and doctors, nurses, even the responsible clinician, that I was using care-seeking behaviours, when, you know, I was just trying to highlight the fact that I was poorly, and, you know, dismissed and just generally given another unhelpful label. But with PACT, you know, they've been extremely accommodating for my needs, and, you know, always treated me with the utmost care and respect, you know, dignity, everything like that. Everyone at PACT, you know, they just respected my opinions around therapy. You know, Amanda and Elle, they've been absolutely fantastic. You know, they both listened to why I didn't want to, you know, go through certain therapies again that, you know, I'd been through so many times before and haven't been helpful. And, you know, together, like, we worked and come up with a solution for what would be the best option for me, with me being included throughout the whole process while making these decisions, which for me was a really alien experience, to be involved in making decisions around my own care. Amanda and Elle, you know, they used techniques that worked best for me, and it took time to find these, but they were willing to give me that time and support me to find the right techniques that worked. You know, like with Elle, we used the grounding technique of the 5 senses, but she left me a voicemail, kind of like talking me through the steps to make me feel more grounded, which I saved from my phone to be able to use, at times when I needed it, when I was out and about at home, wherever that might be. Amanda did the same as well for some exercises learned in the therapy sessions. And for me, it's just been an invaluable tool to have. And, I think Amanda and Ella have both sort of thought outside the box with how to approach that, which again, I haven't sort of experienced anything like that before. But when you're in the state of heightened distress, for me personally, I can't think clearly. I can't remember what I need to do. I can't think of the steps what I need to do to get myself out of that distress. So by having this available to me when I needed it, and having Elle at the end of the phone talking me through each step, giving me a little bit of a pep talk at the same time, it's just been so helpful. And like I said, not something I've experienced before. And I just want to highlight as well that this is something that I still use. I'm not even part of the service anymore, but it's been that helpful that I feel like I can continue to use that. Also, PACT team wanted to build that therapeutic relationship with me, and it was really noticeable. Like they made the time to talk to me, to listen to me. It wasn't all serious all the time. We had laughs and jokes, and as well, you didn't feel like you were wasting their time, which I've often felt with other services before in the past. They wanted to be there and they wanted to support me through my journey. Even at times when I did feel like I was being a burden, everybody at PACT consistently reassured me I wasn't. And again, it just felt like such an alien experience. As well, PACT, everybody at PACT, they've been fully supportive of my university journey, where, other services have been, I guess, dismissing in a way, for saying, this isn't right for me, which, at the time reinforced the opinions that I had of myself, that I wouldn't make anything of my life and I wouldn't have the career that I wanted. But it just proves that anything's possible. I remember saying to Al in one of my appointments that I didn't think I'd make it, past the first semester of year one, just because I lacked so much motivation. I didn't believe in myself. I didn't think I could do it. But thanks to everyone's support at PACT team, I'm going into my third year of my clinical psychology degree, and I guess kind of doing well at my work. But everyone at PACT has been so supportive of that. But I think the consistent theme with all of my hospital admissions and previous care that I've received is that they were all extremely unhelpful. And I think because of the label, of BPD, EUPD, it comes with a lot of stigma. And at the time of my admissions and previous care in the community, it was evident that staff had painted a picture in their head of me before they even met me. Attitudes towards BPD are extremely negative, and again, while I was working in healthcare, it was just apparent that people had this opinion of personality disorders. But PACT have demonstrated that, that hospital treatment isn't always necessary when treating someone with a personality disorder. And I think that their work, that they've done with me shows that community care with the right help and support, it's taken me to a better and more stable place, than where I was at the beginning of my journey. And I've achieved more with PACT than what I have through any sort of hospital admission alone. I know that Amanda and Dr. Cheetham prefer a formulation approach, which for me I completely agree with, and I think it's fantastic. Sort of avoiding the label of BPD and placing more of a focus on symptoms rather than a diagnosis. Not everybody fits into the same box with a diagnosis. Everybody experiences differences in their symptoms. Everyone experiences BPD, personality disorder, in a different way. And, not everybody's treatment is going to be the same. Everybody responds differently. But from my experience, having a previous label of BPD, EUPD, it's been extremely damaging for me. But I think it's important to recognise that there is still, you know, a lot of work to be done around the stigma that comes with personality disorders. And, you know, I'm committed to helping make that change, which PACT have, you know, already started to do. And it reflects in the attitudes and excellent work they do with people who use their service. You know, PACT should have been a service long before now, and I'm extremely grateful for their input on my journey.
Thank you very much, Martha. Jessica, do your colleagues want to add anything to what Martha's said?
Not especially. I think just a massive thank you to Martha for sharing that. And I met with Martha a couple of weeks ago to start planning through it, and I think we had about 2 hours together in the end. And it's just such powerful and inspiring conversations of, you know, the difference that can be made by all of our services as we start to understand people's experiences more thoroughly. And I hope that we can continue on that journey and help many more people to have the experience and positive feedback that Martha has kindly shared today.
Thank you, Jessica. Martha, look, it's a real privilege to hear from you this morning, and I'm really grateful on behalf of the board for you giving up your time to come and tell us your story, which, as Jess says, is inspiring. You know, the where you are currently in your personal journey is just, you know, astonishing, given you know, the nature of the journey up till now. I'm really glad that you've had a positive experience with ourselves, but I also recognise you've had, you know, without wishing to put it flippantly, a bumpy ride, you know, getting there. And there are lots of things that you've said that, you know, I recognise, and that you know, as a board and as a trust, we're determined to be better at. But I'm going to give some of my board colleagues the opportunity to comment and ask questions, if that's okay. So I'm going to start with Jane.
Thank you, Chair. Hello, Martha. Hello, Jess. Martha, we've not met before. I'm Jane Marshall. I'm one of the executive directors on the board. Really brilliant story. Thank you so much for sharing. And there was so much in it that we could ask loads of questions about. My question is, some of the stigma that you experienced and you articulated so well, how do you think people like us on this board can help support both you and patients like you, but also our wonderful staff with addressing that issue, which for you was still there, wasn't it, despite the fact that we know what we know about all of the mental health conditions that are around? So if you've got a tip for us about what we should be doing, that would be really good.
I think for me, I think it's all about terminology that people use, and not being flippant in the way that people talk to us, and just treat us like a human being. You know, we're able to understand things, and, you know, we do pick up on things that people say. So just I think I think that terminology is really important, because the way that I was spoken to many times on my journey, it really did make me feel a lot less human and that I was insignificant and that I didn't matter. So I think that sorry, I'm just trying to think of the words. I think
that's brilliant. And I know other people want to ask you questions, but that's really helped me. Thank you, Martha, and thanks for bringing your story.
No problem.
Thanks, Jane. I think that is a good answer, Martha, because I think, you know, as a big complex organisation, not just in the NHS, but big complex organisations generally, you know, kind of forget that people are people, if that makes sense. And the challenge for us as a big organisation is to retain that human face and the recognition of the humanity of everybody that we deal with, whilst dealing with large numbers of people, and that's a really tricky thing to get right, and I don't think we always get it right, but we try hard, you know, every day to make sure that we do. I'm going to hand, before I hog the floor too much, I'm going to hand over to Chris, who has a question.
Thank you, Kevin. Morning, Martha. Morning, Jess. Thanks for your story. Really good. Really helpful to hear that today. And I think I think what you've really described really well is quite an age-old problem in terms of stigma around personality issues, and I think probably driven by a lack of understanding. I suppose is probably the core of that, but that is in society, but also within our own workforce. And I think, you know, we know that's an issue, and that's something, I suppose, really that one of the drivers behind having the PAC team, but clearly not yet there yet. And I think there's still a lot of work we need to do in educating our own workforce, LPFT, and the wider community. So a big role for us to play in that. I suppose my question, that was more of a comment, but my question really is about thinking about your experiences. What's the thing that made the biggest difference for you? The thing that you talked about how PACT got involved, but what for you personally, or experience of care, what's the thing that changed and made it more positive for you?
I think it was just the general support that I received. You know, it was, like I said before, it was just so alien to me. I hadn't received that before, and it was the fact that they were willing to work with me through my problems, and as well being, like I said before, involved in my own care. You know, not having decisions made for me because I was deemed incapable. And it was just nice to be part of that process and have that say around my care. And like with the therapies, you know, it was always like open for discussion. Like even when starting the therapies, that if it didn't feel right, I was just to say. Whereas, you know, before it was that or nothing. So I felt previously that I had to sort of do that, whether it was right for me or not, and then at the end sort of feel no better. But with PACT, it was more of a, I guess, a person-centered approach. Like you weren't treated as sort of, you know, just another patient with BPD that fits into this category, so therefore we do this. It was very much tailored to my needs, which again hadn't happened before.
Brilliant, thank you. That's really helpful. Thank you.
Thanks, Chris. I'm going to move on now to Tim Harry.
Thanks, Chair, and good morning both, and thank you very much for your very candid story. Jane's actually asked the question I was going to ask, so I'll make a comment if you don't mind, which is I hope that, you know, we as a trust can continue to benefit from your lived experiences to continue to improve what is obviously a wonderful service, the way you've described it. And a sentiment really, I wish you all the best with your degree, and hopefully look forward to seeing you sort of professionally in the future. Thank you.
Thank you ever so much.
Thanks, Tim, and absolutely echo that, Martha. I'm going to go to Sharon next, and then let Sarah, our Chief Executive, have the last question. So Sharon Robson.
Okay, thank you, Chair. Thank you, Martha, for your openness. And what you've done is described today both the worst of care and the best of care. For me, it's been one of the most powerful stories that we've had as a board in the last 3 years. And I don't think listening is enough today. And I wanted to really put it out there to members of the board that we should be taking this story into different aspects of the way we learn and develop as an organisation, such as our training and development and the way we lead the organisation. So it's not a question, it's not something for you to answer, Jess or Martha, but I think we need to capture your story and use it in the way we train staff, and not just our staff, but, you know, the system as a whole to respond to, you know, people who are living with a personality disorder. Thank you.
Thank you, Sharon. I think that's a really, really powerful point, and one that I agree with wholeheartedly. And we do need to make sure that we do more than listen with, you know, interest and respect to what you say, Martha, and that we commit to learning from it, and that we commit to a process for learning from it. And you know, on behalf of the board, absolutely, I do that. So I'm going to hand you over to a last question and comment from our Chief Executive, Sarah.
Thank you, Kevin. And just to echo what everybody said, Martha, thank you so much for joining us today and being really brave in sharing your story. And thanks to Jess and Eleanor and Amanda for joining us too. I just had a specific, really. You talked about advocacy services and how you felt a bit let down by advocacy services. And I've worked in services where it's worked really well and then others where it hasn't. Did you feel able to sort of challenge and share your feedback where you saw it wasn't helping you in your journey and you weren't being listened to? Did you feel like you had any sort of power to change things, I suppose, for the best for future patients?
So when I was talking about the advocating, I meant just on my own behalf. I mean, again, when I was in hospital care, I wasn't even aware of advocacy services until sort of the end of my inpatient stays, you know, which I think is quite a common theme for a lot of people that I know as well. You know, we're just not made aware of that service until sort of last minute. I mean, that's just my experience anyway, you know, especially with being out of area, things like that. But when I did access the advocacy services, they were always fantastic with me. But again, unfortunately, you know, there was, I think it was just sort of a bit beyond what they could do. You know, with trying to challenge like things around my care, I think it was just beyond their remit. But my experience with them, that they were really good when I used them. So.
Great, thank you. And you know, really inspiring story. And just to echo Tim's comments, best of luck with your degree and future studies. So thank you.
Thank you.
Thanks, Sarah. A final thank you from me, Martha, and to you, Jess, and to your colleagues who've sat quietly at the back anonymously. But thank you to all of you for giving up your time this morning. Thank you, Martha, for being honest and, you know, kind of giving us a warts and all picture, which I really appreciate, and I know that my board colleagues have. And finally, good luck, and I'm sure you'll complete your degree studies successfully.
Thank you. Thank you again for having me. I appreciate it.
Thank you very much. It's been good to join you, and thank you again, Martha.
Excellent. Thank you then.
Take care.
Cheers,
Bye.
you too. Bye. Right then, colleagues, shall we move on to our formal agenda this morning, which is a big and busy one. It's my intention to manage our time as robustly as I can this morning to keep us to a reasonable time given the amount of business that we have to conduct this morning. I don't intend to artificially kind of shorten debate and discussion, but a lot of what we need to do this morning is business that has been transacted thoroughly in committee, so I want to make sure that we don't go over scrutiny that papers that we're dealing with this morning have already had, and that we therefore make the best use of the time that we've got and aim to have if you like a civilized finishing time so that we can have a civilized break before we reconvene in private session later today. So with those comments made, Karen, do we have any formal apologies for absence?
No, we don't, Kevin.
Thank you. And does anyone want to make a declaration of interest other than, in addition to those already recorded on the register? I don't see any. So we'll turn then to the minutes of the meeting held on the 26th of May. Does anybody have any comments or points of accuracy on those minutes? Speak now or forever hold your proverbial. I see none, so are colleagues content for me to sign those minutes as an accurate record of discussion at that meeting? Excellent. Thank you very much. Let's move on then to the schedule of actions, where we have 2 open actions, status of which I think are pretty self-explanatory. Has anybody got any questions or comments on those outstanding actions? I don't see any. Thank you very much. Included then at item 1.5 on the agenda for information are the minutes of the Council of Governors meeting on the 21st of April. I'm happy to take any questions or comments that colleagues may have on those. If there are none, then we'll move on to item 1.6, which are some brief remarks from me. Hopefully the note speaks for itself. Only 2 things that I want to add by way of additional remarks. The first is just to note the fact that we're finalising the agenda for the next board development session, having had a really good session the other week aimed at starting to develop a really clear statement of the trust's or the board's ambition on behalf of the trust. It was a really good session and really good to be able to do it face to face, although it looks increasingly likely that the next session we won't be able to do face to face, but enjoy it while you can. So that was good. Really pleased with the way that went, and I think that's a view shared by all the colleagues that I've spoken to. And the second is just to record for the minutes my appreciation to Andy Spring, who's left us as chair of the audit committee, and just to note that we are in the process of recruiting a new non-exec, subject to approval by the Council of Governors, which I hope will be forthcoming quite soon. So if colleagues have questions or comments on any of my remarks, then happy to take them. If not, then we'll move on. Sarah, please, to the Chief Executive's report.
Thank you, Chair. Morning, everybody. I'm Sarah Connery, Chief Executive here at the Trust. Appreciating that we've got quite a bit of business to get through in today's board meeting, I will be brief. So I'll assume the paper is read. Just to kick off, COVID-19 infections in the communities were increasing, and at the time of writing the report and as of today, we do have outbreaks in our services, and also just to point out that mask wearing guidance was amended as well since the previous board. So we're just asking our staff to be vigilant with infection prevention and control measures going forward. Staff do continue to take lateral flow tests twice a week and report on the national reporting portal. As a consequence of the increasing infection rate, we did have to take the difficult decision to postpone our staff awards event, which we were all very much looking forward to. A big thank you to the comms team for being able to get that rebooked in, fingers crossed, in October. So looking forward to that event. In the national regional update, I've just included there some reviews and reports, the fuller stock take as well as the messenger review on NHS leadership, and I'll be bringing back the next steps on those reports at a suitable point in the future. Just to point out that from the 1st of July, NHS Lincolnshire's Clinical Commissioning Group became the Integrated Care Board as part of statutory changes which have been introduced across the NHS in England. So we've had 2 meetings of the board now. I'm a partner member representing mental health, learning disabilities and autism. We had a positive meeting this week talking about health inequalities across Lincolnshire, as well as some of the levelling up work that we're doing together with system partners, including the Towns Fund bid. Just also wanted to point out significant operational pressures continuing within services, with increasing demand and recruitment challenges. Exacerbating that is the increase in COVID infection rate, but also the extreme temperatures that we saw over the past few weeks. I just want to say a massive thank you to all staff for supporting service users and each other to keep services going through what was a really challenging operational situation, but lots of lessons for us to learn as a system as future extreme weather events will occur. And on page 4 there, I just thought the time was right in terms of how the extreme weather events bring into the fore the climate emergency that we face and what the trust and the system are doing in order to play our part in achieving a net zero carbon position. I also just wanted to bring your attention to our Inspirational Leadership Programme event that we held in June. They continue to be virtual. We try and make them as sort of developmental and inspirational for people as possible, even though it's over a computer screen. We had a great turnout and we invited some of our system partners to sort of share their experiences of what it feels like to work with LPFT in terms of positives and negatives, to give a balanced view, and that was really well appreciated by colleagues. We want to be good system partners. Part of that is being able to live by our values, but being able to challenge into the system appropriately as well. So each of the events takes on a focus on our values, and the next session coming up is on compassionate care. I just want to leave it there, and I'm happy to take comments and questions, but again, just want to say a massive thank you to all of our staff, including the executive team, for everything that they do on a daily basis to provide excellent care for our patients. Thank you, Kevin.
Thank you very much, Sarah. Questions or comments, Tim?
Thanks, Chair, and thanks, Sarah, for the usual great quality report. Just a quick comment. Looking forward to getting more of the detail around the messenger review of leadership. I mean, a lot of that looks highly pertinent, you know, collaboration, etc. So do look forward to that. The question I got is quite focused, but it is actually more general than that. So you mentioned around the Lincolnshire Integrated Care Board having its first public meeting, and I just wondered how much public interest there was, but I wondered if you could sort of broaden it in terms of general public awareness of the change to the ICS system.
Thank you. I do believe there were, I'm actually isolating at home myself at the minute because we've got COVID in the household, so did have to join the event via Teams, and there was a problem with the IT, so the public weren't able to dial in as a live event, which was unfortunate. So lessons to learn for the next one, and we didn't have any members of the public in the room. So at the minute, I would say it's been minimal, but lessons to be learned to make sure that we've got public engagement in the ICB meetings going forward, and they will be bi-monthly and interspersed with their own board development sessions as well. So I'll make sure that I feed back on any of those developments through future chief executive reports. Does that answer your question, Tim?
Yeah, thanks, Sarah.
Okay.
Thanks, Tim. I think it's fair to say, isn't it, Sarah, that you know, the ICB's got a way to go in terms of, you know, kind of landing exactly how it wants to work. But, you know, one meeting doesn't make an institution.
Absolutely not. It's finding its feet, and I think the board development sessions will drive real value in making sure that our visions and priorities are all aligned. So yeah, thank you.
Excellent. I'm sure that's right. I don't see any other questions or comments for Sarah, so thank you. We note your report, and thanks for its usual, you know, kind of comprehensiveness Is that a word? It probably is.
We'll go with it. We'll go
Yeah, we'll have it. It'll do for now. So thanks, Sarah. Let's move on then to item 3.1 and the organisational risk register. Anita.
Morning, I'm Anita Lewin. I'm the Director of Nursing, AHPs and Quality here at LPFT. So I am presenting the risk register, and just something I wanted to clarify at the beginning of this, and I'm conscious that at least the last two boards we've kind of spoken about some of the formulation of the risk scores and some of the presentation of the risk register. Made a conscious decision to wait for Jenna to join the organisation, leading the corporate kind of governance agenda, and see if there's anything additional she can bring to us to support kind of the next wave of development of the risk register. So it isn't that some of the points haven't been actioned. I've made a conscious decision to wait really so that we kind of make sure that we include Jenna's thoughts. So in terms of the risk register, it is in front of you. We have 22 risks that are escalated either to this risk register or the private risk register. Additional 28 continue to be monitored at divisional levels. There is a new risk on the risk register which relates to our clinical systems and its ability to kind of record the waiting times of our services accurately, which given some of the issues that we're going to discuss later in the board meeting, it is really quite a critical risk and really important that we get that right. In terms of the risks that are associated with myself, before I pass on to colleagues for any further updates, the one on the risk register that is particularly kind of under my leadership is around the physical healthcare training. I do have to say that the last month has seen us go a little bit off course with the next increase in COVID infections. So we've had to kind of scale back the amount of staff that have been able to attend the training. However, we are on track to kind of, all being well, achieve our required kind of percentage compliance levels by the end of August. So I'm optimistic that we are on track to achieve those, and that should be reduced enough to come off the risk register that's escalated to board. But that's the one that's related particularly to myself, and I'm not aware of any other issues that I need to raise, but I'm happy to pass now over to other board colleagues.
Thanks, Anita. Just a quick question before I bring Chris in. Will Jenna, who is the new Director of Corporate Governance, will Jenna be taking ownership of the risk register, Anita?
Yes. So that is the plan. I may not from the 1st of August, but the plan is that Jenna will take ownership of the corporate risk register. We will give her a little bit of time to settle in, but yes, that is the plan, that it will transfer over to Jenna as the Director of Corporate Governance.
Good. That's what I expected to happen, but just wanted to clarify that, and I think it's jolly decent of you to give her a little bit of time to get her feet under the desk.
2nd of August.
Yeah, exactly. Chris.
Thank you, Chair. Yeah, just want to mention the new risk that's been put on there at 206, which is the one around monitoring and be able to report on waiting times on the clinical system, particularly Rio, which is our main clinical system. We've always had historical solutions in place for monitoring waiting times, which have been reasonable and successful. The issue we've got is obviously with the increase in demand. We've got services now that haven't had waiting lists in the past, and we're getting waiting lists that are quite large compared to what we've had historically. So that's really just exposing a weakness in the clinical system that we're trying to correct. So we're doing some quite good work with our clinical systems colleagues and our business intelligence team to be able to rectify that. And we're nearing a solution for our children and young people services, been testing out a process there that we hope to replicate in other services. So some good work's been done, but we felt it was really important to flag that as a particular risk at the moment. The other thing I just want to flag is risk 155, which relates to COVID related demand on services. I think what we can all see now is that this is becoming business as usual. The demand that we're seeing is not really specifically COVID related anymore, whether it was driven by COVID or not. The increase in demand is now really business as usual and turning into more of an issue than a risk. So I've been talking to the risk manager on that one to review that for next time. But we're doing some work through Sustainability Committee around demand and capacity, and we'll have a piece of work to monitor through that process. So just to flag that we're probably moving that risk to more of an issue, and we'll manage it in a different way going forward, but I'll update board next time.
Chris, is it that the risk is no longer that there is an increase in demand as a result of COVID? The risk is now that there is a permanent or long-term increase in demand, which we don't have the resources or the infrastructure to respond to effectively.
Indeed it is. I think the risks change, so we just need to have a look at the wording of that and probably close that risk specifically and then maybe reopen another risk that's slightly different. So, yeah. But I just wanted to flag that I think we've moved to a different point in time now where the risk and the driver for that demand is slightly different. I think that we're in a business as usual mode that we're going to have to cope with that in a different way. So and I think that leads on to monitoring through Sustainability Committee around how we're going to increase capacity to meet that that current and future demand. So I'll have a look at it and reword it for next time.
Yeah, thank you, Chris. It might be that rather than being a freestanding risk, that plays into the work around financial sustainability and remodelling of services. So there's a number of issues there that interconnect, aren't there?
Yeah, indeed. Yeah.
Thanks. Okay. Any other questions or comments on the risk register? No, there don't appear to be any. Thank you very much, Anita. Let's move on then to item 4.1, which is the minutes of the Quality Committee meeting held on the 14th of July. Di.
Thank you, Chair. Good morning, colleagues. Di Bailey, and Chair of the Quality Committee. It was a busy committee where we considered a number of reports, many of which are on the board's agenda as separate items this morning. There was a good level of activity to give us assurance that we are putting patient safety and quality at the foreground of what we do. I think we just need to be careful that we don't detract from some of those activities by our requirements around some administrative reporting. We heard this morning, I think, from Martha, how important it is that clinicians have time to build and sustain those therapeutic relationships. And Anita and I heard yesterday on a visit that some of that time is being used up by some of our admin systems. So we just need to be careful about that, I think. I just want to highlight two items from the exception report that's before colleagues, and one of those relates to the Mental Health Use of Force Act. So at October Quality Committee, the policy on the use of force will come to that committee, that will then come to board, Kevin, to be signed off, and it has to be signed off by the board of directors in order for us to be compliant. So just to let you know that that's coming. But importantly, section 6 of that legislation deals with the recording of our use of force. And we are required to report that, and that will be reflected in the policy that will come. The issue is that also in that section 6, there is a section that allows us not to report the use of force which is considered negligible. And the committee endorsed the position that the Legislative Committee was bringing to Quality, that actually we felt that in the interests of compassionate care for our patients that is safe, we should continue to report all use of force. The reason why I'm raising this is because in terms of risks, the risk of this is not to patient care per se, it's how we are then potentially going to be an outlier in terms of the level of use of force we report compared to other mental health trusts. So we need to be cognizant of that, recognise that we're doing it because it absolutely aligns with our values as an organisation, but be mindful about what that may mean in terms of some of the data we get replayed back to us. The second item I just wanted to draw colleagues' attention to was the Oakenden review. That this was a request of Quality Committee by the board to review the 4 key pillars of learning: safe staffing levels, well-trained workforce, learning from incidents, and listening to families within the trust. And I think the committee received good assurance that there was activity going on across the trust to demonstrate those 4 pillars of learning. Where we know we have challenges, we're acknowledging those challenges, and we're not being complacent. We're reflecting those challenges in our risk register, the board assurance framework, etc. So I'll stop there and then happy to take any further comments or questions.
Thanks, Di. I've got a comment from Chris.
Thanks, Kevin, and thanks, Di. I just wanted to just make the connection between the Ockenden report and Martha's story earlier about listening to people in the system and how important it is that we learn the lessons. And the report is a powerful kind of statement of families not being listened to, and I think it's equally applicable to patients and the need for us to listen to patients. So yeah, I just wanted to make that connection.
I think if I can just come back there, Kevin, one of the things that we considered at the committee under the terms of reference was the inclusion of the carer strategy as part of the quality strategy, and I think that absolutely reinforces the importance of carers in terms of the overall quality of care to our patients. So I think that's another way that we can heed the importance of listening and taking carers' perspectives on board.
Thanks, Di. Chris, you stole a bit of my thunder because I was going to make exactly the same link. I'm really pleased to see that the way that Quality Committees engage with the Ockenden issue. Colleagues will know that I was really keen that we have something come back to board to enable us to take assurance, to derive assurance that we're not going to commit the kind of errors that Ockenden uncovered. And I'm really grateful to Anita for and her colleagues for doing a chunk of work on this to give us that assurance, which I now have, and that's good. And I'm really happy with where that's ended up. So thank you. And as Chris says, Martha's story illustrates that. This morning illustrated really well the need to listen, but also had a slightly different kind of perspective on it, and that is how we facilitate communication between patients and families that are disconnected by circumstance and geography. But it's fundamentally the same point. And my second observation was going to be on the use of force. Coming from a professional environment where force is unfortunately used on people regularly, I would have real problems with not reporting negligible uses of force, because it's inherently kind of subjective what is negligible and what isn't. And my view, using language from my previous professional life, is that when we put hands on somebody, we should be reporting it. So I'm glad to see that that's what we're doing. It's absolutely right. Thank you, Di. If there are no other questions or comments for Di, then we'll move on and to the safeguarding annual report, Anita, which is you again. It's a bit of the Anita Lewin show again this morning, isn't it?
It could be worse.
It could be lots worse. Yeah.
So I'm kind of presenting the Safeguarding Public Protection and Mental Capacity Annual Report. This has been to Quality Committee on the 14th of July, as Di spoke about earlier. The minutes we've just received, it has had a thorough kind of going over there, but there were a couple of bits in this. I don't intend to kind of labour it. It has been seen by several members of the boards previously, but I did want to draw people's attention to, and we're hearing constantly about the demand on services and the capacity and people accessing our services, but actually it's not just about numbers. The complexity of the individuals that are being referred through to our services now is growing, and the safeguarding team, the demands on the safeguarding team. However, the really positive part of this report, and it is identified in the beginning, is around the numbers of safeguarding referrals that are coming through, the numbers of issues that our staff are kind of noticing and identifying with our patients, and the support that is going into there. It is an excellent annual report. I really like the format that we've worked on with this. I'll go on later to present another couple of annual reports, but we like this format. It was discussed in detail at Quality Committee, and this format will be potentially using for other annual reports going forward. So it is there. I did want to draw attention to the numbers and the complexity that are going through our safeguarding team now, but I am happy to take any questions and comments. You're on mute, Kevin.
I made sure my camera was on at least, so at like 50% right. I deserve some credit for that, if nothing else. I was just agreeing with your comments on the way in which the report is presented, Anita, which makes it easy to read and to digest, and that I think is important for this sort of public document. So thank you for that. Have colleagues got any questions or comments? If not, the requirement is for the board to approve the report for publication. It's published on the website, I believe. Yes. So are colleagues content for the report to be published? Yep, that's great. Thank you very much, Anita. We'll move on then, I think, to item 4.3, which is also you. And this is the Infection Prevention and Control Annual Report.
It is, and I do have to say this is a huge report, and picking up on the comments that I raised earlier around the presentation of the Safeguarding Annual Report, we're going to work with the Infection Prevention Control Annual Report going forward to kind of do something similar. It is an incredibly huge report. It wants, as mentioned previously, this one has been through the IPC committee and then onto Quality Committee, so it has had a really good review. It's obviously been a very challenging time in terms of IPC the last year, as I kind of said this time last year, thinking I wouldn't be repeating myself, but COVID has been and continues to be a challenge for us. We know that we received earlier in the year, in February 22, partial assurance from our internal auditors around some of our IPC arrangements, and this annual report covers clearly the actions that we are taking to address those. It is a detailed report. It does talk at length about the work that the team and the staff in the organisation are doing. But as I say, I'm happy to take questions and comments. It has been looked at in detail by the IPC committee and Quality Committee.
Thanks, Anita. And the question for the board is to approve publication. Yes, bearing in mind, as you say, that it has had a thorough going over in Quality Committee and elsewhere. So questions or comments, Tim?
Thanks, Chair. And yeah, one comment. Yeah, it is a very comprehensive report, so thank you for that. But it does illustrate the amount of work that's been done. Apologies, I may have asked this question before, and I think I was told the answer. Is there any benchmarking data around infection control? I think I have asked it.
Yeah, in terms of outbreaks and in terms of we do kind of reports, so we have to do bi-monthly submissions in terms of we obviously do daily returns in terms of COVID, so there's detailed kind of reports that come out in terms of COVID outbreaks, etc. But in terms of the other outbreaks, we have to do detailed reports, so it doesn't necessarily come out as a benchmarking report as such, but we know where we compare with other organisations. And I do have to say that, and I mean, I probably would say, but I haven't got the evidence in front of me right now. We do compare very well and very favourably with other organisations.
I thought we would, so it was an opportunity. Thank you.
Thanks, Tim. Any other questions or comments for Anita? If not, are colleagues content to approve the annual report and work plan? Yep, that's great. Thank you very much, Anita. Let's move on then to item 4.4, Jazz, which is you and the medical report.
Thank you, Chair.
Jazz, we've got 4 items, I think, in a row from you, so we'll take those and then break and have a short break for comfort and whatnot, just to give you some motivation to get to the end of your items. So,
indeed,
over to you.
Thank you very much, Chair. I will take the report as read, but it highlights really the activity across the medical directorate and domains accordingly. So it starts off really identifying the challenges we've had with recruitment and really what we've been doing around recruitment. And I think it's worth saying that the figures that have been submitted for the purposes of this report are currently under very close, I think, scrutiny and understanding through the medical establishment review, and understanding really the data, because of course the vacancy does not include our long-term trust locum posts. It often doesn't include the posts that have got over the WTEs based on the need for cover, and we're currently working through that. So I expect that for next board report that will be revised. And I'd also add that we've got 2 new consultants starting with us in August and September respectively. So we expect there to be a continued reduction in that vacancy rate. So notwithstanding the above observations, I'd just say that at the moment we're doing a triangulation exercise in relation to ESR data around finances and activity to currently get a good picture of the position of recruitment vacancies. Just moving on to revalidation, we've currently had 5 successful revalidations as noted in the report over the last 7 months. We're making progress, I think, with the Lincoln Medical School, and are now focusing our efforts towards early next year, where we start our medical school intake into healthcare of later life, and how we progress into that from a university and trust perspective, which we're very excited about, and establishing further places for medical students within the organisation, which will put us in a strong footing as we are at the moment with the university, but even stronger than we are. We had our interim quality visit in relation to the Lincoln Medical School, which went particularly well. I've got some highlights on the learning from deaths reports included, which are taken as read, and just one more point around, well, a point around pharmacy. I just wanted to highlight the good work of my pharmacy colleagues, and also the fact that we've now completed EPMA rollout to all our inpatient wards, which I'm extremely proud of, as I was previously interim medical director when we first started the rollout into inpatient medical into inpatient wards, and now I sit here at the end of this stint as the interim, really saying that we've now rolled it out into our inpatient areas as well from an EPMA, so electronic medication prescribing. There's some good work listed from a research perspective, and we continue to try and develop our research, and there's lots of initiatives we're doing. And one point about research I just want to draw everyone's attention to is the conference we had around growing research into Lincolnshire, and how positive I think the feel was for multi-professional research obviously extending it to all professions to enable that to continue. And there are ongoing discussions around that with the Director of Nursing, myself and our clinical research manager on how we can really extend research beyond just singular professional groups. We're also very excited about the idea of the Centre for Rural and Coastal Mental Health and really look forward to how that is developing. So with that, I shall conclude the summary of my report and open up for comments or questions. Thank you, Chair.
Thank you, Jazz. Can I just say, really grateful for the quality and scope of the report. There's tons in here, and it's a really comprehensive and helpful piece of work for which I'm really grateful. I've got some questions and comments from colleagues. So Chris first, Chris Wright.
Thanks, Kevin. Jazz, thanks for a really comprehensive and full report, which provides a huge amount of confidence in the work that you and your team are doing. I'm particularly interested in the relationship between student placements and our own recruitment challenges, with the assumption being that if we can attract student placements, then we might be able to attract people to come and work for us as well. And so the work that's been going on around increasing the opportunity for placements is really encouraging. But I was also a bit concerned about the number of clinicians who are no longer able to offer placements, and just wonder if there's what the reason for that is, or whether that's individual reasons or whether there's a more systemic issue at play.
Thank you, and great question, Chris. I'll begin by saying the benefits from a trust perspective and medical school on our doorstep are twofold in my mind. Firstly, it's the pipeline, as you identified, and I think secondly, it really does improve the attractiveness of the organisation to recruit new staff into an organisation as well. In relation to the placements, I think we are quite challenged at times due to I think clinician schedules and capacity issues around how many medical students can we safely accommodate within things like ward environment or ward round areas. I think we're continuing to work hard on extending the roles so that actually clinical placements don't necessarily have to be just with a consultant. It could be with a range of different other professional clinicians, medical and otherwise. So I think that's a piece of work that we're continuing to do. So I think we're working really hard on that, but there are some limits to our capacity, and I'm currently supervising the lead for the medical students, our associate sub-dean, and it's my intention that we get the right balance between obviously the clinical supervision and obviously service provision. So we are looking at all those possibilities, but thanks for the question.
Thanks, Chris. And thank you, Jazz. Let's move on to Mark.
Morning, thanks, Chair. So good morning, everyone. I'm Mark Platts. I'm the Director of Finance and Information. Jazz, I just wanted to sort of pass on congratulations, really, because without stealing my own thunder for the integrated performance report later on, the work that you and the team and working with HR and people function have done around the recruitment, we're really seeing the benefits in that agency spend coming down now. So just wanted to formally note that, really, especially when we're at a time when only a couple of weeks ago we've had formal notification that the national caps around agency spend are coming in. So some really great work that's putting us in a really good position there. So just wanted to note that. Thank you.
Thanks, Mark. And I just want to thank the team that have been working so hard on this from a workforce perspective, from a finance perspective, and I think from our clinical directorate and medical management team perspective. It's everyone's contribution that's really made a difference. So thanks, Mark, for noting that.
Thanks, Mark. And Jazz, I just want to echo that. I mean, it's notwithstanding, the risk and, the difficulties around medical workforce recruitment. What's demonstrated here is a genuine grip on both on numbers and on spend that provides the board with a significant degree of assurance that we are managing effectively through those difficulties. So thank you.
Thank you, Chair.
Tim.
Thanks, Chair, and thanks, Jazz, for, as everybody said, a really good report. So we talked quite a bit about recruitment. I just wanted to pick up on something in your report, which is around the other side of the coin of retention. And there's a line which is around comparing the previous 6 months with the last 6 months, what appears quite a big improvement in retention. Now, accepting that these are quite short periods, so is it a true trend or not? I wondered if you got any insights into what has maybe caused that reduction, or sort of increase in retention. Sorry, we get it right.
Thanks, Tim. It's a really good question. I mean, we recently had a developmental day for the first time for a long time. So I think one we had was prior to COVID, and we managed to get the development days are a good opportunity to really have that moment to discuss what the issues are, try and work towards them. And of course, we were very keen to use the staff survey findings and take that away and look specifically at the medical directorate and maybe focus on some of those points. So currently the medical workforce, was being written, the focus areas have been taken into consideration about support, about value, about making their voices heard, and job planning as well. And I think there's a piece of work actually progressing some of that that remains ongoing. One thing I would say is that the medical workforce, generally speaking, has, over the last few years at least, has had some very positive retention rates. And I think it is a sense of cohesiveness within the directorate and division. I think it's a sense of connection with the organisation. And I think it's also about how I think we connect with the actual workforce itself. So making sure that their voice is heard and making sure that there are those listening opportunities and that we respond to when there are some problems. I think working this organisation, it's a smaller organisation than most, so we can have personal relationships, and I think that does make a difference.
Yeah, thanks, Jazz. That's really helpful. Thank you.
Thank you.
Thanks, Tim. Thank you, Jazz. I don't see any other questions or comments. I've already said my piece. You know, it's a really comprehensive, helpful report, Jazz, that provides, you know, a good level of assurance across the breadth of the work that you've been leading. So appreciated. Thank you. We have to stick with you, I'm afraid, for the next 2 or 3 items. So the next item, 4.5, is the Guardian of Safe Working annual report, which comes to the board to note, having, I think, been considered elsewhere before it gets to us.
Yes, thank you very much, Chair. I just wanted to highlight the report that gives a breakdown of the activity for the Guardian of Safe Working. And as people will be aware, the new junior doctor contract includes the position of the Guardian of Safe Working. So in our trust, it's Dr. Vijay Waikar, who also works as an older adult psychiatrist. And so submissions made for the board to consider and also have regard really about assurance in relation to doctors in training in their hours. What I can say to the board is that the report should offer some degree of assurance that the contract and the activity in relation to the rota for junior doctors is being managed in a successful way, and that there are no significant breaches. We do recognise the challenges of working as a trainee, and in this current climate, of course, with COVID and with the exceptional challenges on workforce. But I think that the report really offers that sense of reassurance that we are operating in a safe environment. So I just ask the board to consider and commend the report.
Thank you, Jazz. The report speaks for itself in that regard. Have any colleagues got any questions or comments? I don't see any, so thank you for that. That's been received by the board, Jazz. Thank you. We'll move on then to item 4.6, which is the Learning from Deaths report.
Thank you very much, Chair. So, as board members will recognise, we are required to have a mortality surveillance group and committee to ensure that we monitor and take any learning we can from deaths of patients that have been in touch with us as an organisation. So the Mortality Surveillance Committee does meet and offers some standardised reviews, so mortality care reviews, where there are instances where there's been deaths that haven't been covered by the usual SI safety processes. So I put forward the report, which I take as read, which really highlights some of the work that is currently underway. I would just highlight that we now have an organisational learning group, which is really trying to connect different strands of our governance so that we can be as inclusive as possible to really improve what we do from a quality perspective, which of course the Director of Nursing does now chair. I'd also mention that we do have now an established medical examination office in all acute NHS trusts, and that all organisations will be supporting this by the end of March 2023. So that there are just certain points I just wanted to raise, but there is nothing else that I wanted to necessarily raise in the report, so I'll leave it up to questions and comments. Thank you, Chair.
Thank you, Jazz. The report, I think, speaks for itself. Questions or comments from colleagues? Di.
Thanks for the report, Jazz. A comment and a question from me, I think, which is broader than LPFT. So the report alludes to the annual health checks in terms of, you know, one of the areas that is challenging for us. We know, I think, that, you know, we've got some challenges around physical healthcare training and making sure that we're, you know, we're monitoring patients' physical healthcare needs. And we heard earlier from Martha about how important that was in terms of her journey through the service. I'm just cognizant of the wider system issue around waiting lists and access to things like, you know, GP appointments, and I just wonder how we as a system are taking that into consideration in terms of, you know, making sure that that patients are getting the physical health care checks where and as when they need them, really.
Yeah, thanks for the question, Di. I think that's an ongoing challenge for our patients to achieve, and I was very interested with the comments raised this morning in our presentation that actually diagnostic overshadowing, which is when individuals are often labelled as having mental health problems and they actually have physical health problems. It's a huge challenge, I think, for us as a group of mental health providers. Now, what I can say about that is that we're starting to have very much open conversations with the new integrated care system with our partners, and we're starting to put a bit more challenge into the system about the need for physical healthcare checks. Now, we are scrutinising that. It's part of our physical health strategy that we work with partners and we work to enable the right care. And I think we need to be doing more, and we need to be challenging ourselves much more. And I'm sure Anita would want to add to that. So I'm going to stop there.
Thanks, Jazz. Anita.
Thank you. And Jazz is absolutely right. I've been quite vocal, really. You'll all be surprised to hear about making sure that it isn't just about numbers, and we have been reporting kind of increased percentages around our annual health checks. But I'm very keen that we really look at the quality of those annual health checks. They're not a numbers exercise. So we are taking that through the new system quality committee. I've spoken to kind of the Integrated Care Board Chief Nurse there to say I really want us to start to address the quality, because the latest leader report that's come out has really indicated that we haven't seen any shift really in the life expectancy, so that is something that we're looking at. As an organisation, we've really focused on the annual health checks, and the physical healthcare team, under, to be fair, the leadership of the Community Services Division, Nick Holden, the Community Services Division, we've really kind of increased the quality of our physical health checks for the SMI kind of caseloads that we have. I know that Sarah, as the chair of the Mental Health Learning Disability Board, is also looking at the annual health checks. It really is a key focus for us everywhere, and as I say, making sure that it's not about numbers, because it's not about numbers. So yes, so it is a really key focus for us.
Okay, thanks for that.
Thanks.
Thanks, Anita. Sarah.
Thank you. Just to build on Anita's point, one of the key focuses of the work, there is quite a detailed work plan around health checks that's sort of co-owned by the ICB and our trust and primary care as well, is to make sure we're targeting people who didn't have a health check last year. So there's something about the quality of the health check. There's something about making sure we're capturing people. It isn't just a numbers game. And if you check the trends, we see that sometimes it's the same people who are coming forward. So really getting to the bottom of people who do find it a challenge to access those health checks. And just the second comment to make is one of the key priorities of the Mental Health Learning Disability and Autism Alliance, which we'll talk about at the next joint board with Council of Governors, is to have a mental health, learning disability and autism informed society and workforce. And that means the whole workforce within the health and care system. And there's continuing traction around, for example, the Oliver McGowan training, whose mother came to one of our previous nursing conference sessions to make sure that reasonable adjustments are made when people with vulnerabilities are accessing mainstream services. So just wanted to add those comments. Thank you.
Thanks, Sarah. And Jane.
Sorry for the delay. Jane Marshall, Director of Strategy, People and Partnerships. I welcome those comments from Sarah, Anita and colleagues on the importance of this. I just wondered, Chair, if I may, through the ICB, the Integrated Care Board, I wondered whether there is the opportunity for patient stories as part of that that board arrangement, and if there is, whether, for example, stories like the one we heard from our patient this morning, from Martha, might be part of those processes to illustrate where integration could actually benefit patient care.
I honestly don't know where the ICB stands on that. Not being a member, Sarah may well know whether that's something the ICB intends to do.
Right, it's a great point, and I'll put that forward at the next meeting. Thank you.
I guess the only word of caution around that is that it doesn't tempt the ICB to start getting into kind of operational issues, and that they use that kind of opportunity to learn at a strategic integrating kind of level. But I'm sure they will. I think for me that this whole discussion, and Di, thank you for the comment that sparked it, does two things. It illustrates the potential value from working at system level to integrate services better. But it also, for me, there's a link with the discussion we had around Ockenden, because it's not just about do we systematise physical health checks, but it's also about do we listen to people. So one of the things that came out, really strongly from Martha's story this morning was not that her physical health wasn't being checked, it's that she wasn't being listened to when she was telling staff that she felt ill. So it's the connecting point of both of those issues, isn't it? We can do better system wide to kind of systematize our response to all of that, but we can be better at responding to people when they just say, I don't feel very well. And that's what I think you described it as, did you describe it as diagnostic overshadowing, I think, Jazz, which is an excellent term. There's significant, kind of learning and scope for being better around that, it seems to me.
If I may, Chair, I think that's really important. I think for me, the integrated care system, this is one of the population health inequalities that we need to, I think, challenge our system partners around, because we know that the rates of physical health morbidities, the overall life expectancies are very different for the population we serve in mental health. And it's so important we get this right. And I've committed a lot of my professional life looking at this. And the shift has to move from activity to outcomes. What makes a difference? How can we make a change in people's lives? And I think that's absolutely critical, and we need to focus our energies on that. So thank you very much for that point.
Yeah, no, thank you, Jazz, and thank you for the report, which is well received. Thank you. We'll move on then, colleagues, if we may, to item 4.7, which is your last item, Jazz. You'll be relieved to know, which is the Mental Health Act annual report.
Thank you very much, Chair. So this report has been presented at the Quality Committee earlier. It gives a breakdown really of some of the background to the recent changes and challenges with the Mental Health Act, starting off with, of course, COVID-19, including a comment around the new Mental Health Act and the use of electronic paperwork, as well as some of the descriptions of Mental Health Act governance that go into some specifics around the use of the Mental Health Act. Broadly speaking, there's nothing really to highlight that's particularly unexpected in the governance related to the use of the Mental Health Act. I would add that following Quality Committee, I think there was a helpful comment about what happens when we put people on a section 2, which is a 28-day section. What's the outcome? So that's included in the report. That was an update from Quality Committee 1. The objectives from last year and the current objectives are listed, but I would just summarise by saying that there's been really good practice from the Clinical and Mental Health Act team, and I thank them for their continued hard work. And there continues to be a focus on quality and good governance within the systems, as highlighted by some of the CQC reports that we've had. So that's all I wanted to say, Chair. So I'll open up for comments and questions.
Thanks, Jazz. Question from Sarah.
Sorry, I'm struggling to get my camera on. Thank you, Jazz. It really great report. I just had one question about how we're cutting our data in terms of one of the key purposes of the ICS is about reducing health inequalities, and I didn't know whether we have got any data around Mental Health Act and through the lens of protected characteristics. So I don't know whether we've done that piece of work. Thank you.
Yeah, thanks very much, Sarah. In fact, there's a project currently underway looking at this and in effect of segmenting the data on Mental Health Act. I mean, I would suggest that this is probably quite a useful item for the next board report to perhaps have a division by protected characteristics of the use of Mental Health Act. And I think it leans towards some of those changes for the forthcoming Mental Health Act, which is very much a focus around how we deliver and improve access for those with protected characteristics, and avoids the more formal use of the Mental Health Act or access to inpatient areas. So I would commend that actually as the approach we take, and something we report into board around, so we can start using that data to understand how we're improving access to people with protected characteristics. So thanks for the point, Sarah, and I certainly recommend that if that's the will of the board.
Thanks, Jazz.
Yeah, I think that's almost certainly what the board would want us to do. Thank you, Jazz. Sharon.
Hi, Jazz. It's just a point of clarity, really, because I'm still struggling with the statistical process chart around section 17E, which I understand is recall.
A
Is that right?
Community treatment order, that's correct, yes.
Yeah. And what I'm struggling with is, in terms of an explanation around that chart, does that mean that those patients that were you know, sent into the community and then recalled should not have been sent out? Or, you know, is there any safety issues around that? That's what I'm trying to determine.
So it's a good question. It just captures the number of patients that were recalled at any given month. So it doesn't really necessarily relate to the duration of how long the community treatment order was on. I'm not aware of any such issues, but we'd probably capture it with our readmission rate data better than we would on this particular SPC and graphical response. So I don't think the data currently will show that level of detail. Of course, we can dissect that in a bit more detail, but that's just the total numbers of recalls.
Okay, thank you.
Yes, so I would expect that if there were lots of recalls that happen suddenly, but we can probably match that up with the number of CTOs. There'll be a way of doing that, and certainly we can comment on that if needed.
Okay, thank you, Jazz.
Thank you, Sharon. Thank you, Jazz. The requirement for the board is to note the report, I assume.
That's right, Chair.
Good. Well, thank you very much for presenting it, and you know, it's a helpful report, comprehensive, and from which the board can derive assurance. So I'm grateful for that. Thank you. If colleagues are content, I propose that we take a 10-minute break for those of you that want to make yourself a cup of tea or coffee or take a comfort break. So it's currently 10:31 by my clock, so let's reconvene at 10:40. Thanks very much. Okay, welcome back. Colleagues, let's continue with the agenda and item 5.1. Tim.
Thank you, Chair. So as with the other committees, it's been a busy time. There were just three things I really wanted to highlight to the board. One is we reviewed and have made a set of recommendations around a series of annual reports. Just a general comment, I think they all show improvements in most areas, but there's still room for improvement. But one of the things we do need to consider is what the ambitions of the trust are, and obviously that's part of the board development session. I won't say any more about those reports as Jane's going to cover those. The second point is around the risks around recruitment and retention, and obviously as previously reported, we've focused a lot of our time on those areas. This last meeting in June culminated in a deep dive on that area and formed the main part of the meeting. So we had a lot of detailed data and analysis on progress, and particularly around a lot of the control measures that are being put in place, such as the pipeline, modelling, international recruitment, medical recruitment, attraction strategy, and walking in your shoes. That all demonstrated, I think, considerable progress across the patch. What we did recognise, obviously, was that the risk is still high, but the control measures we now believed are in a more robust and assured position. And that led to a review of the board assurance framework in those areas. So a lot of work by Jane and her team, and we commended the progress made. The final area I really wanted to pick up on was around one of those key control measures and mitigations, which was around international recruitment. This formed the story that we had at the beginning of the meeting, and it highlighted a lot of the good stuff around that in terms of the level of pastoral care, well-being support, onboarding and training. And I think it's really important that we get this right, as obviously we're now looking at quite a large number of posts to be filled through international recruitment. What the individual highlighted was the rapid response and good access to support that the individual had, which again is obviously important, and also support for the different cultural experiences experienced by the individual. You can't necessarily predict all of those, but I think you need to be able to respond rapidly around those. You know, they crop up in all sorts of areas. The final bit around that was leading on around international recruitment. We had previously discussed the ethical nature of it, and a position statement was compiled for board consideration around that. And I think the key thing around that is the phrase partnership. It's a partnership. It's a two-way process that we're looking at. So I think those are the main things I wanted to highlight, but obviously open to questions.
Thanks, Tim. So there are two distinct elements to your report on there. There's the general kind of progress, which is for the board to note, and then the position statement on international recruitment, which is for the board to approve.
Yeah, sorry, I should have made that clear. That's right.
No, that's all right. Don't worry, that's my job. It's fine. So any questions or comments for Tim? I really liked the position statement. I think it meets the the burden of the kind of message that the board has discussed in the past and the kind of statement the board wanted to make. The final paragraph is the bit that's particularly important to me, around how we reciprocate with the countries from whom we are borrowing staff, as it were, and that fits the bill. What's the thinking around how we publicise that statement? Where does that statement fit in? How the trust communicates.
Good question. Sorry, can I just make one quick one? A big thanks to Jane and Anita, because it was from their conversation around the international recruitment and ethical statement that sort of led to that particular statement.
Thanks, Tim.
Jane.
Yeah. Jane, and then I'll come to Karen.
Thank you, Chair. Jane Marshall, Director of Strategy, People and Partnerships. I think as a board we might want to consider the ethical statement on international recruitment as part of our Just Culture work, Kevin, and communicate it as part of that broader signal about achieving fairness and justice across staff groups and patient groups. That would be my thinking. I just think it's so important that we do take time to consider communicating that well.
Yep, agree with that, Jane. And I wonder too whether or not, as part of our general, kind of comms activity, when we are talking to the community at large and our partners about our international recruitment efforts, whether or not we might want to work some elements of, without rolling the statement out every time, making sure that we reflect the thrust of that statement in our more general comms around international recruitment, and agree with Sarah. It's definitely one for the annual report as well. So sorry, Karen, I left you waiting. So come back to you.
That's fine. Thank you very much, Chair. I'm Karen Scott, Acting Trust Secretary. I was just going to suggest that in addition, we appropriately locate the statement on the Trust website. We include the board statements and declarations on issues such as safeguarding, freedom to speak up, and I think given the current climate and the importance of this, it will really be relevant and raise the profile in the public domain.
That's an excellent suggestion, Karen. Let's do that. Thank you. I don't see any other questions or comments from you, Tim, so really grateful. Thank you very much. Let's move on then to I should have put the question to the board. Forgive me. Are colleagues happy as I am with the statement on international recruitment, and happy to endorse that? Forgive me. That's great. Thank you very much. Having backpedaled slightly, we will then move on to item 5.2, which is the Equality, Diversity and Inclusion Annual Report. Jane, and that's you.
Thank you, Chair. Jane Marshall, Director of Strategy, People and Partnerships, presenting this report on our Equality, Diversity and Inclusion activity for last year, 2021-22. And it's a duty of public sector organisations to put on the record their actions around equality, diversity and inclusion. So this report, subject to approval today by the Board of Directors, will be published. It has been considered by the People Committee, and that scrutiny happened in June this year, as Tim Harry, the chair of the People Committee, highlighted in the previous item. And it covers both our EDI, Equality, Diversity and Inclusion activity, as an employer, but also as a service provider. I'm really proud that in an exceptionally difficult year last year with the pandemic and everything that brought, we used some of our inclusion processes to really help our communication, particularly with our staff networks during the course of the year, to check in with them, given they've identified with protected characteristics, and support them with everything over the last year and listen to their voices. So the bottom of page 1, I've summarised there the key highlights for last year, and also included in the report, Chair, are the actions for 2022-23 on page 2 of the cover sheet, which we are on with. I suggest, given the Acting Medical Director's comments about the Mental Health Act and protected characteristics, we include that as one of the actions for 22-23, just to tie in that loop. Happy to take questions from colleagues. Thank you.
Thank you, Jane. As you noted, the report's been thoroughly examined in People Committee, so it's had an appropriate degree of scrutiny before reaching board. It's a report that is comprehensive and reads well, so you know, a huge credit to those responsible for pulling it together. Have colleagues got any questions or comments for Jane? If not, are colleagues happy to approve the report for final presentation? Excellent. The answer to that is yes. So thank you, Jane, and thanks for an excellent report. We'll move on then to, where are we now? 5.3, the Employee Relations Annual Report.
Thank you, Chair. Jane Marshall, Director of Strategy, People and Partnerships. This report is presented to the board today for information and is the annual summary of employee relations activity in the year 21-22. It was considered by the People Committee in June and scrutinised by them for assurance purposes. And there were 2 comments, if I may, Chair, that came up as part of that seeking of assurance. Those were the time taken in days, which is highlighted on page 4 for us to complete investigations. Just to confirm, that is not a mandated target. It is a best practice target, and it's informed by several national reviews, including by the then NHS England Chair, Dido Harding, and we aim within our trust policy for 30 days. Some of the investigations are very complex, particularly those that involve police colleagues. So when you take out those those complex cases, we're at 51 days on average time to take to complete. So we've more work to do, but we're aiming for that 30 days. And the second point, if I may, Chair, was that to confirm that as part of 3.1.5, there were no formal disciplinary cases in either the older adult, corporate or medical divisions, just to make that point of clarity. Thank you, and I'm really happy to take any comments.
Thanks very much, Jane. My one observation was going to be on exactly that point about the average length of investigations. It might just be, and this might just be a presentational point, Jane, that because the numbers are relatively small, and because we have these outliers, that an average time doesn't really tell us very much, partly because it is so distorted by the outliers. And I wonder whether it might be more helpful for future reports just to show an actual distribution of the lengths of time, because we're talking about a couple of dozen cases, aren't we? And we could easily show a graph of the actual distribution of time taken to resolve each of them, rather than trying to produce an average. That might just give us a little bit more information, or help us to interpret it a little more readily.
I think that's exactly right. So a distribution rather than an average would be really important. And I think there are other tweaks to this report for next year that we could use to improve it, given the small numbers that you identify there. But just to give the board assurance, our prime objective, and I think we're making progress, is to ensure there's the least formal intervention, and that we take as little time as humanly possible to complete the investigations, which obviously for those involved are distressing but I will absolutely make that addition to this report and future ones. Thank you, Chair.
Of course, Thank you, Jane. And of course, you know, the aim is not to have any, but while we do, I think that would be probably a better way of presenting those data. Questions or comments from colleagues? I don't see any, so the board receives and notes that report. Thank you, Jane. And we'll move on then to 5.4, which is the 2022 Gender Pay Gap Report.
Thank you, Chair. Jane Marshall here again, Director of Strategy, People and Partnerships, presenting this report on the gender pay gap for 2022, which again, as a board, we are required to publish our data as a result of the discussion today and this report. It was considered by the People Committee in June, and you'll see on pages 10 and 11 of the appendix the actions we are taking to improve our position, which in summary, when you look at the average pay per hour between males and females in our organisation, there is an 18% difference in favour of our male colleagues. So included in the report, I think, is a really helpful analysis both of the data, but also the actions that we are taking as a team and as hopefully approved by board to address that gap. Key within that are some of the clinical medical excellence awards that are applied for by our medical colleagues, and we are undertaking a piece of work to ensure that everyone feels able to apply for those awards irrespective of their gender. So again, happy to take comments, Chair, but this is a report for approval today. Thank you.
I'm grateful. Thank you, Jane. And thank you for noting that point. Because this is a report that we're required to publish, so therefore the board needs actively to approve its content. I've got comments from a couple of colleagues. Chris.
Yeah, thank you, Chair. Yeah, Chris Higgins, Director of Operations. Thanks, Jane. I've seen this in previous iterations, and it's a really good piece of work. I was just picking up on the issues highlighted in the conclusion around that. To balance the gender pay gap, we've got to do two things. One is increase the proportion of women in higher paid roles and increase the proportion of males in lower paid roles. And I'm just thinking in terms of that, there's quite a big section on supporting female staff. I'm just wondering if through maybe in the overhauling recruitment and careers progression, whether we wanted just a specific action in there around targeting campaigns around males into the lower paid roles. We know that support workers, peer support workers, domestic roles aren't commonly undertaken by males, and whether we need to whether it's worth doing something specific on that. As my only comment.
If I may respond to that,
yeah,
Chair.
thanks.
I think
Please
that's
do.
an excellent. Sorry, Chair. I think that's an excellent point, Chris, and I think maybe through the Men's and Allies staff network that you and Mark Platts, our Director of Finance and Information co-chair, we could get some of those campaigns out. And there is some useful work that you've been part of and you'll know about around competency frameworks for those lower banded roles and progression. So hopefully we can combine the two and get some campaigns going to attract more males into our organisation, given the male-female split that we've got. So thank you for that.
Thanks, Chris. Tim. No, Sharon next. Apologies.
Okay, thank you, Chair. Jane, it's just a comment really, and I know in terms of the gender pay gap is reducing year on year over the last 3 years, and understanding the work that's going on behind that. But given the split of males, females in the organisation, as demonstrated in your papers, which were very clear, is it enough quick enough is my question.
That's a really good challenge, and I think we are affected very considerably by that huge differential. There's 80% of our staff are females and 20% are males, but I do think there is targeted action we can take as part of our Just Culture approach as a board, which says these are the campaigns that we are backing that we hope will make a difference. And Chris and I have just spoken about one. I do believe it's possible to make further progress if we target our expertise, capacity and time in the right ways. So thank you for the question.
Okay, thanks, Jane.
I mean, it's good to see that the direction of travel is, in the right, in the right direction. I think Sharon's right to challenge whether or not we're moving quickly enough and whether or not we can, if there's anything we can do to improve the pace of that. So I think that's a good point, well made. Tim.
Thanks, Chair. It's really just following up on Chris's point and the conversation about male recruitment. And it's not something I asked in the People Committee, so apologies, I should have done at that time. Do we know why there has been that significant reduction in men going into the nursing profession? Because we can have campaigns, but how do we need to frame them, target them to get the real desired outcome?
If I may invite Anita Lewin, our Director of Nursing, in chair to comment on that. Anita's got some thoughts.
Yeah, certainly, and it's something that we're actually picking up nationally, because the change is quite considerable. And I mean, and I know it was a long time ago, but when I started psychiatry, certainly in psychiatry, there were more males, and it is a definite shift. We have in the past actually had permission to target specifically male recruitment a few years ago now, certainly for some of our male inpatient wards, to help with some of the mix that we needed on those areas. A little bit unknown, if I'm honest, Tim. I've actually had a conversation. My son goes to an all-boys grammar school, and I've had a conversation with his head teacher and kind of asked about kind of some really targeted focus work, because I don't think people understand what we do in psychiatry, especially. I think it is seen as a female profession, but I think there is definitely something for us to do, certainly for us in LPFT, around psychiatry and the specifics that what we do. And I know Chris and Mark have had several conversations about the male staff network and how we can support that, and doing some staff stories. I've actually been asked to go and speak to the Prince's Trust and speak to a large audience at the Prince's Trust, and I have spoken to them, and a lot of the audience is male, and it is about talking through the profession and the options really, and just targeting wherever we can.
Thanks. I wondered if there was any national research, not a question to be answered.
Lots of people saying we're not really sure why, but we need to do something about it. Yeah.
Okay, thank you.
Just an observation on that, Anita, and I'm sure you're right that engaging with boys at school is really important, because boys need to understand that nursing, and mental health nursing in particular, is a career that might be of interest to them. And I don't want to chair by anecdote, but if colleagues will permit me one brief anecdote, when I took my 9-year-old son to, well, I didn't take him, he was there with his school at the Lincolnshire show the other week. There were plenty of stalls telling him why he should be a soldier or an airman or a whole range of other things, but there was nothing there presenting the NHS and telling them as a small boy he might be interested in being a nurse when he grows up. And if we don't engage boys at that sort of age, then we lose them. Jane, I don't know whether your comment is one that you've already made, but I noticed that you've had your hand up metaphorically.
Thank you, Chair. Just a brief one. I wonder if, given the discussion, we need to take this report as part of our Just Culture discussions in board development, and really, pressure test some of those challenges and what we want to do about them.
I think it plays really well into a wider discussion about workforce composition, about how we develop, as you say, a just culture. So yeah, absolutely. But for right now, though, the board is asked to agree the report and the action plan. So can I have an indication from colleagues whether or not they're prepared or happy to do that? The answer appears to be yes. So thank you, Jane, and thank you for that. Thank you, colleagues, for that constructive conversation around those issues. Let's move on then to item 5.5, Jane, and we're still with you.
Thank you, Chair. This paper is presented to the Board of Directors for decision. We are required, again, to publish our data on the workforce race equality standards, and this report summarises both the trends in the data, but also, more importantly, or as importantly, the actions we are taking to achieve further improvements in race equality. And the next phase of our work, I think, is to enable people at all levels in our organisation to engage and work together to address some deep-rooted cultures on race inequality in the NHS widely, not just our organisation, learn more about it and build capacity and capability in our workforce to address it. We've made some good progress, but I think, as it might have been the chair of our People Committee, Tim Harry, commented earlier, we've still got big challenges left that we really need to address and work on, not least as part of our approach to retaining staff and making sure that, for example, those international recruits that we've recruited to come and join us stay with us and don't experience any disadvantage or discrimination because of protected characteristics that they may have. So again, Chair, here for approval. It has been to the People Committee. Happy to take any comments from colleagues on the board. Thank you.
Thank you very much, Jane. Di.
Thanks, Jane. I just noticed in this report and in the previous report, there's reference there to colleagues who aren't stating information that is helping in terms of the information that we need to collect about protected characteristics, race and gender equality, etc., etc. And just looking at the actions, I think the actions are about how we try perhaps to level up some of the some of the stats that we've been talking about. I just wonder what we're doing in that space, which is enabling colleagues to feel that they can state, protected characteristics, race or gender issues, because I think it's, there obviously are a group of our colleagues that either don't feel able or don't perhaps, need to understand or feel a bit more confident about disclosure, I guess.
Thank you, Di. It's an excellent point, and I think the way that we plan to tackle it, and I will add something specifically into this report, is around two main ways. The trust communicating to say, please engage, please disclose, it's safe to do so, you can do it quite easily, and because actually if we know about you, we'll be able to work with you and listen to some of the things that might help you with your staff experience. So a communications piece, I think, and linked to that, a relaunch of the staff networks, because you'll see from the previous report at 5.2, the annual report on equality, diversity and inclusion, we need to double our efforts to get people involved in those networks, to identify chairs of some of those networks. So that's my plan, to do it through those primary two routes, but also to ask the board to consider what messages we can be giving out as a board to encourage people to disclose that information. I will add that into this because you're right, it doesn't include that specifically in the action plan, but I will add that in. Thank you.
Thanks, Di. Any other questions for Jane? I don't see any. So are colleagues then content to approve the publication of these data? Yep, the answer to that is yes. Jane, thank you very much. Thank you for a really helpful report, well presented. Thank you.
Thank you, Chair.
And we'll move on. I think this is your final item for this morning, which is item 5.6, the Workforce Disability Equality Standard Report.
Thank you, Chair. I'm presenting the equivalent to the paper we've just considered on workforce race equality to workforce disability equality, and I've separated this out into a separate report because I think it's really important that we consider them as separate items. So the evidence we've gathered, sorry, I should have said this is for decision again to publish the data, and also it has been considered by the People Committee. The evidence confirms that many disabled staff continue to experience inequalities in the workplace, and this was exacerbated by the COVID-19 pandemic. Key to our actions, I believe, Chair, is, and the executive team has signed up to this, us focusing on gaining level 3 accreditation as a disability confident employer. We're currently level 2, but we're planning a piece of work which has been approved by the executive team to gain that level 3, and we're engaging and co-producing the response with our MAPLE staff network, which is people with physical mental health and physical lived experience. So that's a piece of work we've already launched. There are other actions in this report as well that are highlighted here, but I think our work with our staff network is particularly important as we take this forward. Thank you, and again, happy to take comments from colleagues.
Thank you, Jane. Questions or comments from colleagues? My comments that applied to the equivalent report on race and equality apply to this as well, Jane. Excellent report, good piece of work. So the question then is, do our colleagues content to approve publication of the report? Excellent, thank you very much, and thank you, Jane.
Thank you.
We'll move on then to item 6.1, which is the Integrated Performance Report. Mark, this is the moment you've been waiting for with eager anticipation for the last 2 hours.
Definitely, Chair, definitely. So good morning, everyone. So I'm Mark Platts, I'm the Director of Finance and Information, and I'm here today to present the Integrated Performance Report for July. The report is based on June data, unless otherwise noted within the report, and kind of builds on what are being refined but established reporting processes within the organisation, and it provides key highlights on areas of focus to both the board and the public around some key areas of focus. So with that in mind, if it's okay, I'm going to hand over to our Director of Operations, Chris Higgins, to take us through the operational updates.
Okay, lovely, thank you, Mark. So I've been a little bit like a stuck record on some of this, in that the biggest operational challenge we're finding around performance delivery is rising demand for services and workforce availability, and that's been like that for some time now and continues to be the kind of main driver for performance issues across our services. There are some other contributing factors around. There's some new access targets that we've been set as part of the NHS long-term plan that require us to see increasing numbers of people, and again, having the capacity to be able to do that is a challenge, particularly with the workforce pressures that we're finding ourselves in at the moment. Really the way forward with that, whilst we're doing as much as we can to increase our workforce through recruitment and other opportunities, we're doing a piece of work over this next year, for the remainder of this year, to really go through each of our services and do a demand and capacity analysis to understand what's the workforce blueprint that we need to deliver the expected activity levels and meet the demand that's presenting itself, and also unmet need that we know is out there for a number of people. And we're going to monitor that through the Sustainability Committee and really hopefully be able to, as I say, create workforce blueprints for each team that are challenging, innovative, and will eventually deliver the planned activities that we need to. So that should be an interesting piece of work to follow, and will put us in good stead for the future. There are some particular areas worth noting this month. One is the early intervention in psychosis service. That's a service that has been seeing increasing demand again over the last few months in particular, but also we're challenged with workforce as staff have moved on to different new interesting roles. It's created gaps in the workforce, and so we've got a demand and capacity gap. We are putting a bit of a business case together to discuss with our commissioners around increasing the capacity of the service because of that increasing demand. However, there's two limited factors there. One is the money, whether that money is going to be available, but more likely is about workforce, and we can increase the investment to the service, but if we can't get staff, then that's, I'm not sure how successful that's going to be. So simultaneously, we're talking about new models of delivery and really pushing on what is one of our trust values, which is innovation, and saying that we need to think differently here. If the workforce aren't there, then that's what else could we do? And so at the minute we're just exploring different opportunities, different pathways that we might be able to implement so that we can actually maximise the resource we've got and see the people that need to be seen. So we'll bring more information about that back, but it's a difficult time for that service as they're struggling with demand, but we're thinking of new and innovative ways to manage that. On a positive news story, Children and Young People Services, board will be well aware of the pressures on that service and that we've had increased investment into that service over the last few months. We're starting to see the success of recruitment, particularly in the Lincoln teams and the North teams, and we're now seeing a reduction in the number of people that are waiting and a reduction of the number of people who are waiting a long time. So really positive to see that tide turning. Hopefully we'll be able to sustain that, and that's the start of an improvement trajectory that we've set out with the Sustainability Committee. It's not quite there yet with the South, and particularly in the Boston areas where recruitment's a particular challenge, but hopefully things will follow suit in the other parts of the county, and we'll see that progress continued. So feels like we're just turning the corner with CAMHS, but still a lot to do, and still people waiting longer than we would want them to do. Dementia is a similar story in that we've got increased number of people presenting for treatment and support, a demand and capacity gap. We do what we can to fill those vacancies, and a bit, I suppose it's a similar message across most of the services. We've tried to set indicative trajectories for when performance will be back on track, but that's really difficult when you rely on a workforce pipeline that's so challenged. And so what these are caveated with is we've set indicative timeframes, but that's on the basis that demand doesn't increase further, and it's on the basis that we're able to successfully recruit, because without those two factors coming to fruition, we'll end up in a kind of perpetuating circumstance of people having to wait. So we are doing everything we can on that. We're working proactively with our recruitment teams, thinking differently about models of care to try to maximise what we've got, but it's a challenging time for some services. What would say for CAMHS, or Children and Young People Services, and for dementia, in recognition of that, in recognition of changing landscape, in recognition of the opportunities that the voluntary community sector can bring, we've triggered full transformation programmes across the system to look at how we can, the broad spectrum of resources that are out there, look at the totality of spend and how we might be able to use that differently. So the short-term plans to improve performance here and now, but longer-term transformation projects that will maximise the resources overall. So yeah, I'll probably leave it there and take any questions.
Thanks very much, Chris. I've got Di and then Chris Wright. So Di.
Thanks, Chris. Di Bailey, Non-Exec Director. So a couple of comments and question from me, really, I guess. So in terms of the wait times, I think we know that they are a challenge, not only for the people who are waiting for services, but I'm particularly struck by the impact that this is having on carers and families. So for me, I think there's something about, in terms of thinking about that innovation, how we might reach out across the system again to maybe third sector organisations or other parts of the system that can provide that support to carers and families to prevent, I guess, some of the breakdown of care that is only going to make the demand on some of our acute services more challenging. So I suppose I just want to make that comment. it goes back to my earlier point, my question about physical health and psychological health, and heard yesterday from staff in a community mental health team for older people about how some of the physical health issues, when not addressed, are being represented as presentation of psychosis particularly. And again, I just wonder whether we have information that we can use again across the system to maybe understand the population needs in a more holistic way, I think, rather than just people coming through the doors of our services. So I'd be interested to hear your thoughts on that.
Yeah, thank you, Dave. Just in terms of the supporting people while they're waiting and whilst in treatment services, we do a lot of signposting through our website, but obviously through individual services to other care agencies, community involuntary services sectors that are out there. There's more and more services coming online that can support people, and so we do try to signpost where we can. And also then within the trust, we're setting up some kind of support services, the balance between using resources to do support people whilst waiting rather than using the resources to see people whilst in treatment. But certainly good examples in our children and young people services, where we've now got an access team to make sure that referrals are streamed to the right place first time, and also when we've got family liaison workers that are contacting people whilst waiting to support both the service user and parents to make sure that the wait is as effective as it can be. The data one on physical health is a really interesting one, because you're quite right that we get presentations into mental health services that actually have got physical cause that can be treated, and so I'm not sure that we're coordinating that in the best way we can. So it's absolutely a good piece of work to do as we work as a system, certainly through the dementia work and that transformation that's going there about how do we pull that data together. I should imagine we're collecting that at a local level in services, because we'll understand that as we do our own diagnostic testing, but making sure that we're collating that and using it and sharing it in a different way. There's obviously some work to do, so I'll make a note and I'll share that with the divisions.
Thanks, Chair. Thanks,
Di. Thank you, Chris. Chris Wright.
Thanks, Kevin. Thanks, Chris. This kind of links a little bit to the previous question, but and it's a kind of comment and a question. But I was at the board development day. We were setting out the ambition for the trust, and part of that ambition is how we can deflect people from formal interventions. And so I'm struck by the thinking around innovation and how we're going to organise ourselves perhaps differently to manage demand and reconcile some of the challenges around workforce. And it just struck me that we need to be telling that story. And so how are we communicating that to the population we're serving? So when people look at the statistics and the waiting lists, they also can see the thinking and the innovation that's going on in terms of trying to organise ourselves in a way that can manage demand in a more innovative and imaginative way.
Yeah, just happy to comment on that. I think the work we've done through the adult and older adult community mental health transformation program is really showing some really good signs, because what I think has happened in the past is that there's been a range of support services available in the community through community involuntary services that have been probably uncoordinated and fragmented away from secondary care specialist mental health services. And so what we've tried to do is bridge that gap, not only in terms of communication, talking to each other, getting people around the table, but also we're now looking at sharing systems, being able to use tools and assessment documents and care planning tools that can be shared across and can be recognised across pathways. So if somebody's discharged from our service or transitions into another part of the system, they can be familiar with what we're trying to do and continue the work, and vice versa. And then those routes of escalation, if somebody deteriorates in their mental health, they can then escalate quickly to specialist support. And I think that what we're learning through that, we started to replicate around the county, and certainly as we move into the dementia transformation work, the children and young people's transformation work, we definitely want to use that model of coordinating and connecting into that community sector, The other limiting factor at the moment is that there's a capacity issue in that community voluntary services sector, and I think there's some work for us to do as an organisation about how we stimulate that market so that we've got a much broader range of support services that are going to meet the needs of people that we currently see. So absolutely the direction of travel. There's something to do with us as an organisation coordinating that, but also using our influence to be able to stimulate that market a bit more.
I agree with that, Chris, absolutely. And I just think we need to be getting some stories and making sure that we're telling people what we're doing, so that there's a kind of greater awareness of the activity that's underpinning some of the work that you and colleagues are doing around just thinking differently, getting some good stories out there so people can have confidence that there are new ways of approaching these issues.
I think if I may, Chris, that's a really important point, because most of our comms around access to services is defensive, and there's a degree of inevitability about that, but we don't start to create some of those stories by talking about how we want to improve and transform services. Can I a couple of observations, Chris, if I may? The first is possibly not a massively helpful one, but for me, I take a significant degree of assurance from what you've presented this morning, but I do think it for me underlines some of the limitations around how we present our performance data. And I'm not looking for an in-depth discussion around that today. It might be something that we pick up offline, because what we don't see, what we see headline performance target metrics and an explanation that underpins it that talks about increasing demand, but we don't see those demand figures, and we don't see that performance, kind of overlaid on demand and overlaid on workforce. And I think there's something around how we present an integrated set of data that enable us to understand where the correlation is between demand and waiting time, for example, and we can see that more graphically. And I'd welcome, Mark, if you were up for it, an offline discussion about how we might present some of that differently, and it might mean moving away from just a straight presentation of performance metrics and contextualizing them with data that I know we've got, a bit more effectively, that provides a kind of richer picture. So that's my first observation. But as I say, that might take us a while to play out and land somewhere that we're happy with. My second is a kind of linked to Chris Wright's point, and it's about signposting. My hackles always rise a bit when I hear that term, because at its worst, signposting is just giving somebody a leaflet and telling them to go and ring these other folk that might be able to help. I hope what we do is kind of supported and enabling signposting, where if we're recommending that people make phone calls or refer themselves to somebody else, that we help them do that. Because putting yourself in the shoes of a patient or service user who's having trouble being expected to navigate things unhelped is not the best place to be necessarily. And to go back to Chris Wright's point about starting off the back of the board development work we're doing, starting to develop those stories of where we want to be, and socialising those, to use a dreadful term, I think is a valuable thing that we can do. But thank you, Chris. As ever, a really good explanation of where we are and a high level of assurance that we're doing the right things. So thank you. Let's move on then. Who's next, Mark? I lose track of where we are. It's Anita.
Thanks, you.
Anita.
So moving on to, I thought I'd frozen there. So moving on to the quality section, and actually picking up on the comments you raised, Kevin, it is something that we're looking to do too, against mapping kind of incidents, patient experience, and the whole quality agenda against the conversation we've just had. So one of the first things that we're doing, so we know Datix recording is quite onerous at the moment. We are underway kind of getting a new system which will help some of that, but we are actually now reporting on the day of the incident rather than the day of the Datix, which kind of is quite a fundamental change really, but it will help us with some of that triangulation against kind of the staffing and kind of where we are on that day in time. In terms of the graphs, that they are there for you. Self-injurious behaviour continues to remain our number one kind of SI issue at the moment. And I know it has been kind of conversation that we've had this morning. It is a real issue for us as an organisation. It's a real issue, obviously, for the service users who are experiencing that. And we spoke earlier, having listened to Martha's story about the training and skills and knowledge of the workforce. Our nursing colleagues, certainly as part of their nurse training, do not cover kind of self-injurious behaviour and that work around that. So I'm linking closely in with the university, but we are within LPFT kind of looking at the skills and knowledge of the workforce around how we support kind of some of that kind of behaviour that's occurring on our units and to keep our patients safe, which is our ultimate goal. In terms of medicines management, we do, and I know that's been an issue of the kind of the board and the focus of the board, but just to give assurance that there are really detailed reports that go through to the Patient Safety and Experience Committee on medication incidents, and Medication Safety Group also monitors the outcomes in terms of learning. Just wanted to focus on kind of the complaints that we received and the expressions of satisfaction graphs that you have there. Now I have to be honest, if you've got hard copies, it will make life much easier, but the expressions of satisfaction received, large apology to colleagues, and it was only when I spent a considerable amount of time trying to work this through, I realised it had actually printed upside down. So it isn't as it seems. We have seen a slight dip in expressions of satisfaction, but not the marked dip as it would identify here. But also the complaints received, we've also seen a reduction of those, although I do have to say, and it's based on some of the conversations we've had about lots of things, whilst in number some of the complaints have reduced, the complexity and ensuring that we get that right and get the responses right for the people that have made the complaints is really becoming a lengthier process, because we're really keen. I would rather spend a bit more time and get the response right than people having to keep coming back to us. I've included in this, we've done a self-assessment against the draft PHSO draft complaint standards, which we know are coming in kind of spring 23, but I always like to be on the front foot with these pieces of work, and we've got really key kind of headlines of where those standards are going to go. So we have been undertaking a self-assessment, and you'll see some of the outcomes there. And the next step of the patient experience team and quality and safety team is to work through our complaints process and ensure really that it does what the people kind of put in the complaints, and that it meets their needs. We are working really closely with the Carers Council to help to reach out to people that have made complaints in the past to see if kind of the response has been as they would like. Now, obviously, the service they received initially wouldn't have been as they liked, else they wouldn't have gone through the complaints process. But it's important that we kind of get their feedback on being on the receiving end of that process. So they're key focus of the team at the minute. Moving on to the quality section, there is about safe staffing, and we've heard this morning, you know, and there is no getting away from it. It is really tough at the moment in some of our operational services, and maintaining safe staffing is really a key issue for us. In terms of some of the control measures and mitigations, we do find ourselves redeploying staff from leadership roles that have kind of gone into the leadership roles, and as a board we heard from out of hours coordinators some months ago. We are redeploying staff in to keep some of those services safe. We have had an increase yet again of staff absences with COVID, so it is a challenge for us, and not one that I can move away from. You know, we've presented to board and we've heard from Jane Marshall, Chris Higgins and indeed Jazz, full the medical director, director of operations and director of people around all the work that is going on. But it is a challenge. It's you know, we are reaching out to our staff. We are hearing and listening to some of the things that they tell us. And my NED colleague Di Bailey made reference to the fact, and it is some real feedback that we're getting at the minute about the administrative demands on our clinical staff. It really has come to the forefront in the last couple of weeks on some of the feedback we've had about administrative demands. So I've agreed to take the lead on some of that. We need to take that administrative burden off our staff to allow them to focus on caring for our patients. So it is a piece of work that I've agreed to kind of take the lead on and look at what we can do about that. But safe staffing is tough, and this isn't about the numbers. This is about us kind of achieving what we know we have already decided are our optimal staffing levels. Lots of work going on, but still an issue for us. So I'm just going to leave it there, and I'm happy to take any additional comments.
Thanks, Anita. Di.
Thanks, Kevin. I just really wanted to amplify Anita's point about the, you know, the review of administration. Really, I think we heard it this morning from Martha about the importance of time and staff availability to listen. And I think in terms of our increase in self-injurious behaviours, you know, we know from the research with this population that where we're seeing these care needing behaviours, one of the things that really makes a difference is time. Even if it's somebody saying, you know, I just need to do this, but I'll be back with you in 15 minutes, and I will sit down and have that time with you there. And so I think anything that we can do in terms of giving our clinicians the time to be available to individuals, I think we should, you know, we should do all we possibly can in that space. Given the challenges that we've got with our clinical workforce and recruitment, I think if there's anything that we can do with non-clinical recruitment to alleviate that burden, you know, we should take that very seriously.
Yeah, thanks, Di. I completely agree with that. No, I can't see any other questions or comments for Anita. Shall we move on then? I think, Jane, you're up next.
I am, Chair, thank you. It's Jane Marshall, Director of Strategy, People and Partnerships. I will cover the people section of this report and particularly focus on page 20, where we have our vacancy rate. So we've plotted that out, and we are seeing the highest level we've seen for a number of months in terms of the level of staff vacancies. In terms of that position, because of our analysis we've done on our data and the fact that we have a vacancy dashboard, and it says this in the text, we can now focus on the areas where we have got the highest turnover rate, and we are doing so, including having a link with the work my colleague Chris Higgins described on the demand and capacity work, but also a plan for every vacancy, so that we are able to use the data we've got to really focus and get grip on the individual vacancies. In terms of your point, Chair, about correlating information, there is an opportunity through this. We're planning through the workforce dashboard to split out those vacancies or those posts that are associated with growth in our services. So we'll be able to then correlate the investment with the activity that's required with the workforce needed to deliver them, and then think about new roles, as the Director of Operations was describing. So it's a real opportunity, I think, to really focus on some of that correlated data. Finally, I just wanted to say thank you to my executive team colleagues, because we really are pushing now the scope for creating new roles within the organisation to address our workforce challenges. And you'll see, Chair, from this report, we have a minimum of 70 new whole-time equivalents coming into the organisation to bring our vacancy rate down, which will be new roles, which is really important that we take every opportunity we can to do that. So thank you again, happy to take any questions.
Thanks, Jane. And I think that's, you know, a really positive step, being able to strip out, as it were, in vacancies that are linked to new services or new investment from, you know, if you like, business as usual vacancies. Okay, any questions or comments for Jane? I don't see any. Thank you very much, Jane. There's a position there that, you know, we're kind of familiar with, but familiarity doesn't mean that, you know, we're not focused on the risks that all of that presents. So don't take the lack of comment as lack of interest. Mark, I think it's back to you in finance.
Excellent, thanks, Chair. Just before I go into the finance, if that's okay, I just want to pull out a couple of the trust-wide metrics that are in page 27. And I think this kind of builds upon your feedback really to the start of the report. I think we'll look at how we bring the data probably back into the forefront of the report to give that context and pull it through. But Chris has talked through the majority of the outliers, certainly around the CY, the children and young people, and early intervention and psychosis. But there are a couple that I did just want to kind of pick up on, which draws the whole of the conversation that we've had on this integrated performance report together really. The first one is around the perinatal access rate, which is metric 23, which is on page 28. So this is a great example really of how getting that data and working with Jane and Chris and the people team to understand the consequence of not recruiting to vacancies that we have in that service, how that's materialising in not only the access rate, but the length of waiting lists that we've got across services and pulling it forward. And perinatal has been one that we've talked about over a number of weeks really to understand. And I think we've got a plan of action for taking some deep dives through sustainability committee around this, and we probably need to understand how we can bring that data to life through the integrated performance report as well and move that forward. So works in motion to help improve the reporting around that. The other one I did just want to pick up from the trust-wide metrics before I go into the finance area is the metric 7, which is around the Lincolnshire IAPT services. Treatment to waits at 34%. That's something that I know Chris and the service have been working hard on, and actually one of the intentional actions that's gone through that is an intentional investment in agency to support that. So there's been a big influx of agency staff to support whilst trainees are going through their development programme pushing forward. So that should be improving over the next couple of months as well. So I'm going to link that back into the finance update if I may. So a couple of key bits I did want to pick up on. And again, I stole my own thunder earlier on during Jazz's presentation on the medical report, is around the use of agency. This is going to become a very big focus nationally now that we are kind of moving away from pandemic in terms of recruit and fill posts at all costs. This is now going to be how we effectively manage the use of our workforce and agency support. The Lincolnshire system, we have now received our agency cap in inverted commas, so the most that we're authorised from NHS England improvements to spend on agency. That is at a system level, that isn't at an organisational level, so we do need to work out how we work closely with system colleagues to manage that really. But in terms of LPFT and where we're at, I've touched on that intentional use through the IAPT service, which I think is a really key focus to work on that, and also the success around medical agency and the reduction in that is taking our agency spend down to low levels, so we can only see improvements in that as we move forward. But in terms of our overall performance, we are meeting our revised financial plan submissions. So our year-to-date surplus is a surplus of £1.2 million, which is positive variance on our plan. So that is a financial representation of all of the challenges that we've talked around in terms of staffing vacancies and the challenges on the service really. So again, it's always a difficult balance, isn't it? Because the challenge around service delivery often results in a positive financial position, which I don't necessarily see as a success, but it's important that we manage that moving forward so we can do the right things with it. Agency utilisation, whilst it is over plan at the minute, I do think the work that Jazz and the team and wider colleagues have done on medical agency is going to bring the lion's share of that down. So we will be meeting our internal target by the end of the year, really. And the final one to mention is there are ongoing challenges around capital expenditure. The market, the challenges around the conflicts in Ukraine is really impacting on market and supply chain and materials. So our biggest scheme, which is the development of our 2 acute inpatient awards on the Lincoln County Hospital site, has seen some impact, but the project team are working really hard with our supply chain partner to make sure that we keep that momentum on the scheme and look for alternative sources of equipment and providers, really. So we're on track to deliver it, but we're not quite hitting our year-to-date position in terms of expenditure around that, but we will do by the end of the year. So happy to take any questions on both the trust-wide metrics and the finance section, Kevin.
Thank you, Mark. Sarah.
Thank you, Sarah Connery, Chief Executive. Thanks for the report, Mark. And I think, you know, context is everything, isn't it, around the agency spend. So it's really useful to know in terms of meeting the access standards. That's, you know, what's driving some of the agency spend. And we have said previously as a board that we won't compromise on performance and quality to meet the agency cap. Albeit a system one, but obviously that breaks down into organisational level. So I just wanted to say, I suppose it goes without saying that I want to reiterate that sometimes agency is the answer. Thank you.
Thanks, Sarah. Completely agree with that. I've said on a number of occasions, both you know, in public and elsewhere, that as chair, I'd rather be beaten up for spending too much money than not doing the right thing for patients. And that's a kind of approach that I will stand by. I don't see any other questions or comments for you, Mark. So thank you, and thank you to you and colleagues for walking us through the integrated performance report so well this morning. Really appreciate it. Thank you.
Sure.
Let's move on then to item 7.1. Tim.
Thanks, Chair. So again, another committee that's been busy, hence 3 sets of minutes in the pack. This is all to do with scrutiny of various statutory reporting, particularly around year end and accounts, etc. So we've been looking at some remaining internal audit reports, the internal audit annual report and the head of internal audit opinion. There's also been the external audit of the 21-22 trust accounts. And also the trust annual report and annual quality report. So obviously a lot of this has gone through as recommendation to the main board. So by and large, all very positive and giving assurance to the board. The one thing to note is around the external audit of the accounts, which had not been completed on time, but I hasten to say that is purely down to the external audit capacity and not to do with anything with inside the trust. The draft report, though, that we have had is again fine, and what is being said, it's very unlikely to be any significant difference by the time it is sort of formalised. So all that sort of activity. A number of updates around standing instruction, financial instructions, delegations have been put forward to the board. You've got the annual speaking up report, and that's on the agenda next. The only thing I was going to mention was another annual report, which was around counter fraud. This demonstrated very positive progress. And I think in particular we should know that the local counter fraud specialist is doing a really good job and making a significant impact in this area. So I think, Kevin, that's probably all I wanted to highlight.
Thanks, Tim. And I should have said, thank you for stepping into the breach and presenting all of that in the absence of a substantive chair of the audit committee. So I'm grateful. Any questions or comments for Tim? I don't see any, so you've got off lightly. Thank you very much, Tim. We'll move on then to, as you've already alluded to, Tim, the Freedom to Speak Up annual report, which I think you're presenting, Sarah.
Thank you very much, Chair. Thank you. So I will assume the paper and report are read, but just to highlight a few things that I'd like to bring to the board's attention. The report has been through the audit committee in July. Just want to say a massive thank you to our Freedom to Speak Up Guardian, Stu Nielsen, who's a great resource for our organisation, but also the system and nationally as well. And also to Di, our non-executive director, Freedom to Speak Up champion. So this is the 5th year that we've had the Freedom to Speak Up Guardian. And as you can see from the report, we do continue to see an increase in the number of concerns raised each year. The report does highlight that there is a strong correlation between having a substantive full-time Speaking Up Guardian and actual reporting in organisations as a benchmark. So we do see it as a positive thing, but look with interest in terms of where that might end in terms of number of concerns being raised every year. The key, one of the key percentages for me in the report is 100% of those in our organisation who have raised concerns have said that they had a positive experience and will do it again. So that one's really important for us to note. The National Freedom to Speak Up report from last year did show that the culture of organisations nationally had shown a slight decline in terms of the experience that Stafford has when they raise concerns. So I think we should all be proud of that. I think it's worth saying that the report is a reasonably positive one. I think in terms of the learning, if you go to the back of the report, you can see how the really pragmatic actions that are taken as a result of those concerns that are raised. So again, massive thank you to Stu for building the report, and I'm happy to take any comments and questions. Thank you.
Thank you, Sarah. I just want to echo what you say about the value that the Freedom to Speak Up Guardian Stu brings. That's immeasurable, and it's reflected in the report. Also, agree with your point, Sarah, that I'm not at all fazed by the number of people coming forward to speak out. It's the mark of a healthy organisation, and going back to Jane's comments earlier about a just culture. It's all part of the same piece. So excellent. Comments or questions? Anita.
I just completely agree with Stu. He's absolutely incredible, and I've never heard anything but positive from the staff that have gone to him. But and it was a comment I wanted to raise, and I meet regularly with our CQC inspectors to ensure that kind of our engagement continues, and we always share details of our Freedom to Speak Up. They're always incredibly impressed by the low number of anonymous kind of issues that are raised, and the fact that our staff feel able to kind of raise them and be public about that, rather than it, certainly as part of the benchmarking in areas that they've been elsewhere. There's a lot that come through anonymously, and that is not something that we see in LPFT. So I think that's something for us to kind of recognise too.
Yeah, absolutely. Very good point. Thank you, Anita. There are no other questions or comments. Are we noting this, or what are we doing with it?
It's for decision, Chair. It's for decision. Yeah.
Decision in what sense? To approve it, and is it published? Yeah. Okay. Colleagues, happy to approve the report. I think I'm getting to that stage in the meeting where I'm struggling to string a coherent sentence together, so apologies. But I think the end is in sight. So let's move on then to item 7.3, which is annual report of the Quality Committee. Di.
Thanks, Karen. Di Bailey, Chair of Quality Committee. So this is a report for information. It basically provides details of the work of the Quality Committee over the last year and is required as part of the governance arrangements that we have to submit as being a foundation trust. So I alluded to it earlier in terms of this did go through Quality Committee on the meeting of the 14th of July. So I'll take the document as read, but happy to take any comments or questions.
Thanks, Di. Comments or questions? I don't see any. Thank you, Di. So reports received. We'll move on then to item 7.4, Board Assurance Framework. Karen.
Thank you, Chair. Karen Scott, Acting Trust Secretary. So this is the board's quarterly review of the Board Assurance Framework. This version has been in the majority been reviewed by the Audit Committee and recommended to the board for approval. The only exception being that following the Audit Committee, the Quality Committee had another meeting. So there are some further changes highlighted within the quality section of the document, which have been made since that review. Just one comment, I think that the Board Assurance Framework is now becoming a really dynamic document, and the board's committees are really using this proactively, and it's evolving, changing and becoming very, very useful and helpful document. So recommend it to the board for approval.
Thanks very much, Karen. Questions or comments? Are colleagues therefore happy to approve the Board Assurance Framework as presented? Excellent, thank you. And sticking with you then, Karen, for item 7.5.
Thank you. So I'll take the paper as read. It's very self-explanatory. Following the Trust Secretary's retirement from the organisation, it was important to note that there's a vast range of documents and processes within the Trust that actually refer to the Trust Secretary and the title and the responsibilities. Given that we have a new Director of Corporate Governance joining us next week and we will no longer have a Trust Secretary in title, it's important that we actually address that in all of those documents. But rather than do that wholesale, which would be a huge task, it's recommended that we actually do that as things become due for renewal and review. So there's a statement included within the document which the board is asked to consider, and subject to approval, we'll place that on the policy page of the Trust website, so that it's very clear to everybody that those changes will be made in due course and as those documents become due for renewal.
Thank you, Karen. That's looks straightforward and a helpful statement. Colleagues are happy to endorse that. Excellent, thank you. And then sticking with you, Karen, for the forthcoming board programme.
Thank you, Kevin. This is the routine board programme diary for the forthcoming quarter. So all significant meetings are there highlighted in detail. And just to highlight, as referred to previously in the Chief Executive's report, following the Trust's move to increase its infection prevention control measures, again by the reintroduction of mandatory mask wearing, we'll need to continue to carry out risk assessments for any planned face-to-face meetings of the board or council of governors, unless anything changes in the until such time that anything changes. So it's just here for the board to note.
Yeah, thanks, Karen. Questions or comments? Don't see any. So the final substantive item of business is by far the most interesting. Mark, the review of standing financial instructions and scheme of delegation, which I've been waiting for with eager anticipation since 9 o'clock this morning.
Brilliant, thanks Sharon. It is a treat as well, it is a treat. So the paper details a lot of the changes that have gone through. Now, whilst there does appear to be a lot on there, a fair bit is the formatting that sort of Karen's picked up in a few other areas really. But I think some of the key bits to pick up around the changes are, we're proposing to increase thresholds around non-pay expenditure. Now this kind of reflects the market conditions and the prices that we're seeing across the globe really, that everything's increasing. So it's important to get a balance of control over your spend, but the flexibility, recognising the fact that market conditions are really inflating prices, and not having governance create a barrier to moving forward and providing safe care really. So there are a couple of thresholds in there for non-pay expenditure where we're removing we had a £5,000 minimum limit before we would look at quotes and tenders, moving those forward. We're increasing that to a higher value of 10,000 to reflect that. So I'm not going to go through the detail, Kevin, of all of the updates. It has been scrutinised through audit committee in a lot of detail and was recommended for approval. So happy to take any questions.
Okay, questions or comments from colleagues? Tim is, I know, suppressing the urge to ask a lot of detailed questions, and I admire his fortitude in doing so. Look, I'm being flippant about it, Mark, but I recognise that there's a lot of detailed work to produce all of this and to get it right, and absolutely endorse the reasons why we're doing it. So please don't take my flippancy as being lack of regard for the work that's done. This is all, as you say, this has all been scrutinised in detail by audit committee. So the ask of the board is to approve, in the light of that, both the standing financial instructions and the scheme of delegation. I'd be grateful if colleagues could indicate that they're content to do that. That's great, thank you very much. Karen, I don't think anybody's indicated desire to raise any other business, have they?
No, they haven't, Kevin, not with me.
Okay, and I don't have any other business. So we're just about done. I'd thank everybody for their contribution this morning. I think we started with one of the most powerful patient stories I've heard in the last year and a bit of being chair, and one that really has caused us and will continue to cause us to reflect critically on the way that we deliver our services. And I think as an organisation that is both accepting of criticism and willing to learn from that, going back to the discussion we've had around creating a just culture, we really should continue to welcome that kind of first-hand challenge. For me, it's shaped a significant element of how I've approached the items on this morning's agenda. So grateful to colleagues for their engagement and contribution this morning. We're due to reconvene in private board. It is now, according to my definitive clock, 2 minutes past 12. So can we reconvene at 12:40 if people are content with that? Unless anyone throws anything at me virtually, I'll assume that's okay, and I'll see you all in just over half an hour's time. Thank you.
Thank you.